হ্যালো হ্যালো Good afternoon, everybody, respected faculties, teachers, my colleagues. So today we gathered here to discuss a issue regarding cricket, management of cricket. So there are a lot of confusion regarding cricket management. So to form a uniform guideline and also to remove our confusion, we have had sorry, this is the diagnosis of cricket. This meeting is for diagnosis of cricket. Diagnosis of cricket.
May I request all the members present here to write down their name in capital letters and their mail ID and phone numbers. And capital bold, that is acceptable.
ডিসপ্লে আসছে কোনটা বলো স্লাইড চেঞ্জার নাকি এটাতে ফরওয়ার্ড এটাতে ব্যাকওয়ার্ড আর এটা হলো ও আচ্ছা আচ্ছা হ্যাঁ দিয়ে দাও May I start, sir? May I start? Okay. So good afternoon, all the ESB members here. উঠে পড় এটা কিছু নেই এই শুভদীপ
কি করবো স্যার ঠিক জায়গায় লাগিয়ে চেঞ্জ হয়ে গেল না
I hand over the session to Dr. Arindam Roy. I also request to come Dr. Sunetra Mondol, Shubhadeep Pramanik, Arindam Roy, Ananta Shankar Choudhury, Rajan Pulai, Rana Bhattacharya. তুমি নেই আমাকে বলো ওকে ঠিক
So thank you, chairpersons. এই দিকটা একটু ফাঁকা থাকলে ভালো হয় আমি যদি এতে দেখাই যে Pointer not working. Pointer not working. To start our consensus, today the discussion will be outlined as diagnostic criteria, classification, initial evaluation to confirm the diagnosis and differentiate the two varieties of rickets, calcipenic rickets, phosphopenic rickets, miscellaneous causes, and final algorithm. Though I have to mention here the pathophysiology and the textbook literature for the rickets that will be discussed a bit in a short form, whereas the diagnostic approach will be discussed in a bigger way. So the recommendation, the first thing, biochemical and radiographic evaluation for rickets should be undertaken in the presence of characteristic skeletal deformities and a disproportionate short stature with short leg in children. Whether to mention the skeletal deformities like genu-varus or valgus deformity, rachitic rosary, and or dental anomalies. So requesting the members to please comment on this. Somebody has to hold the mic.
মানে or
Disproportionate short stature, I accept. It's a disproportionate short stature. Not all those patients who come to us with short stature all have disproportionate short stature. That's why whether it's disproportionate or disproportionate, तो definitely.
Many are proportionate.
Proportionate short stature.
May I comment? মানে বেসিক্যালি মানে বেসিক্যালি শর্ট লিম্ব হলে আমরা মেন তিনটে ডায়াগনোসিসের কথা ভাবি, অ্যাকন্ড্রোপ্লেশিয়া, হাইপোথাইরয়েড অ্যান্ড রিকেটস। তো সেই কারণে এইখানেতে আমরা ওই ব্যাপারটাকে ফোকাস করেছি, মানে ওকে ওকে মানে আমরা ডায়াগনস্টিক ক্রাইটেরিয়া দিয়েছি, ডেফিনিশন বলে দিন, পরের স্লাইডেই আছে, ওটা পরের স্লাইডে আছে। তো এটা কি শর্ট স্ট্রেচার করে দেওয়া হবে তাহলে না? মানে আরটি এর যে শর্ট স্ট্রেচার ভ্যারাইটিটা তারা তো সবসময় রিকেটস নিয়ে প্রেজেন্ট করে না, এমনি মোনোসিমটোম্যাটিক প্রেজেন্ট, ম্যালনিউট্রিশন রিলেটেড শর্ট স্ট্রেচারের মতো প্রেজেন্ট করে।
তবে তো অর শর্ট স্ট্রেচার হলে তো শর্ট স্ট্রেচার
মানে আলটিমেটলি তো আমরা একটা আরটিএ খুঁজছি, মানে কিন্তু ধর আমি আরটিএ খুঁজছি, আমি তো রিকেটস খুঁজছি, সেটা একটা রাইট। এখানে আমরা রিকেটের ইভ্যালুয়েশন কাকে করব সেটা বলতে হবে, এটা জানা হয়েছে রিকেটের ইভ্যালুয়েশন কাকে করব, আরটিএ করতে গিয়ে ফার্স্ট হ্যাঁ আচ্ছা আমরা প্রপোর্শনাল রেশিও আমরা দেখো না, তুমি দেখবে মানে ফর এক্সাম্পল ধরো আমরা অ্যাক্টিভ ফিচারস নেই, একটা সিভিয়ার শর্ট স্ট্রেচার আছে, প্রপোর্শনাল আর ডিসপ্রপোর্শনাল, তাকে কি আমরা রিকেটসের কথা ধরে ইভালুয়েট করব? এটা কি রিকেটসের জন্য করো না ম্যালনিউট্রিশনের জন্য?
মানে তাদের শর্ট লেগ কথাটা কথা
না, এটা এরকম করা যায় কি যে শর্ট স্ট্রেচার পার্টটা পুরোটাই তুলে দেওয়া হলো, অ্যান্ডরের পুরো পার্টটা আমরা যদি এরকম রাখি যে বায়োকেমিক্যাল অ্যান্ড রেডিওলজিক্যাল ইভ্যালুয়েশন ফর রিকেট শুড বি আন্ডারটেকেন ইন দ্য প্রেজেন্স অফ ক্যারেক্টারিস্টিক স্কেলিটাল অ্যাবনর্মালিটিস বা ডিফর্মিটিস। আমার তো মনে হয় তাহলেই তো প্র্যাকটিক্যালি আমরা সেভাবেই ভাবি।
ডেফিনিশন তো তাই হচ্ছে।
মানে আমরা রিকেট যখন আসে আমাদের কাছে তখন তো আমরা কাকে ইভ্যালুয়েট করি, যার ডিফর্মিটি আছে, তার স্ট্রেচার নিয়ে আমরা খুব ভাবি না সেই মুহূর্তে। তো তাহলে ওই সেকেন্ড পার্টটা আমার মনে হয় বাদ দেওয়া যেতে পারে।
থাকলে কি অসুবিধা? অ্যান্ড ডট করা আছে, থাকলে কি অসুবিধা? না, অ্যান্ড ডটটা তো অন্য কারণ। অ্যান্ড শর্ট স্ট্রেচার উইথ লেগ ডিফর্মিটি অর স্কেলেটাল ডিফর্মিটি নেই, প্রেজেন্টেড উইথ ডিসপ্রপোর্শন শর্ট স্ট্রেচার উইথ শর্ট লেগ, সেটাও তো আমার ডিডির মধ্যে থাকবে রিকেটস। হ্যাঁ, শর্ট স্ট্রেচার উইথ শর্ট লেগ, ডিফর্মিটি তো থাকবে। ডিফর্মিটি না থাকলে মানে শর্ট লেগ কি করে হবে?
তাহলে স্যার ফাইনাল লাইনটা একবার যদি বলে দেন। হ্যাঁ, so the final line will be biochemical and radiographic evaluation for rickets should be undertaken in the presence of characteristic skeletal deformities.
Skeletal deformities and or short stature শুধু রাখলে কি অসুবিধা? মানে বাবা মা অনেক সময় শর্ট স্ট্রেচার নিয়ে আসে, তারা বোঝে না যে রিকেটস না রিকেটস না। আমাকে তো বাবা মা শর্ট স্ট্রেচার কমপ্লেন নিয়ে এলে তাকে তো আমি যদি রিকেটস ভাবে অ্যাপ্রোচ করতে হবে, তো পেরেন্টস নিয়ে আসে তো শর্ট স্ট্রেচার। স্কেলেটাল ডিফর্মিটিস এন্ড অর শর্ট স্ট্রেচার শুধু রেখে দিলে অসুবিধা কি? ডিসপ্রপোর্শনেট কথাটা আমি তুলে দিলাম।
ডিসপ্রপোর্শনেট তুলে দিয়ে আনএক্সপ্লেইনড শর্ট স্ট্রেচার।
আনএক্সপ্লেইনড শর্ট স্ট্রেচার
শুধু শর্ট স্ট্রেচার,
শুধু শর্ট স্ট্রেচার
আনএক্সপ্লেইনড রাখা দরকার নেই, শুধু শর্ট
and or short stature in children.
রাখা উচিত, রাখা উচিত। আমার পেরেন্টস অনেক সময় শর্ট স্ট্রেচার কমপ্লেন নেই শুধু নিয়ে আসবে। ভাবছি না, কিন্তু আমি যখন তাকে দেখলাম যে আমার রিকেটস হতে পারে, ডিডিতে আমি ডিফর্মিটি দেখতে পাচ্ছি, অবভিয়াস নাও হতে পারে।
ঠিক আছে, রিমুভ দ্য শর্ট স্ট্রেচার. So proceeding to the next, the diagnostic criteria. The three components: clinical is the presence of characteristic clinical signs, biochemical increased alkaline phosphatase and low phosphate, and X-ray changes is the radiological diagnostic criteria. So what are the clinical characteristics? This is known to all of us. The head craniotype is frontal bossing, delayed closure of the fontanelle, and poor enamel formation. There are different chest, extremities and hypocalcemic symptoms, and at the same time non-osseous features are there. Coming to the biochemical, usually there is
a diagnostic criteria which this is the criteria given by us.
Already suggest করছি।
So diagnostic criteria includes three of us. It is just a diagnosis.
Diagnostic
Features.
রেডিওলজিক্যাল এক্স-রে চেঞ্জেস ক্যারেক্টারিস্টিক এক্স-রে।
স্যার আমি পরে আসছি ওটা ডিটেইলস। হ্যাঁ, in biochemical increased alkaline phosphatase and low phosphate, but exceptions are there, like normal alkaline phosphatase can be seen in hypophosphatasia and some form of distal RTA, whereas the phosphate can be high in CKD or some form of the distal RTA. So in these conditions we have to think for ricket mimicus.
এটাও some form of DRTA রাখতে হবে, যেটা normal phosphate লিখেছিস, some of them may have low phosphate, except in CKD and some DRTA.
Some. So change it. Okay. So these are the ricket mimicus. I am not going in details. Blunt disease. Shunetra. So this is. No, this is sir we have made. নিজের হাতে লেখা বানানো. You can proceed.
These are rare things.
রিকেটস মিমিকার্সের মধ্যে আরেকটা আছে চাইল্ডহুড হাইপার প্রাইমারি হাইপার প্যারাথাইরয়েডিজম।
ওটা রিকেটের মধ্যে রেখেছি
হ্যাঁ
আমরা রিকেটের মধ্যে রেখেছি ফসফেট ইনডিউসড আসছে
মিমিকার মানে ওটা অ্যাকচুয়ালি তো রিকেটস না, কিন্তু রিকেটসের মতো মিমিক করে ম্যাসকুলারিটিং লোয়ার লিম্ব ডিফর্মিটি নিয়ে আসতে রিকেটস নয় কেন? হাইপার প্যারাতে তো তোমার বোন মিনারেলাইজেশন ডিফেক্ট তো নয়, বোন মিনারেলাইজেশন ডিফেক্ট নয়, এবং তোমার সমস্ত এপিফাইসিস মেটাফাইসিস ডায়াবেটিস তিনটে পোর্শনেই তো ইয়ে হবে না, অ্যাবনর্মাল নয় তো, প্যাথোলজিক্যাল নয় তো, মেনলি তো তোমার ডায়াফাইসিস। সেকেন্ডারি হাইপার প্যারাথিস এখানে তো মিনারেলাইজেশন ডিফেক্ট আর ওখানে তো অস্টিওক্লাস্টিক রিডাকশন অস্টিওক্লাস্টিক রিডাকশন মিনারেলাইজেশন ডিফেক্ট থাকে না। আর এটা সমস্ত বনের সমস্ত পোর্শনটাকেই মানে ইনভলভ করে। হাইপার প্যারাতে মেনলি তো
আগের স্লাইডে দুটো বক্স ফাঁকা ছিল কেন?
So it is sir. Sir, actually only more than 150 slides we have, so we can fast a bit, then it will be yeah, sir. So that's why we need to do it a bit fast. Okay. So we are proceeding for the next. So these are the diagnostic features for the X-ray changes what sir was mentioning. So that is also known all of us. So I am not going in details. I am skipping. So the recommendation 2. A diagnosis of rickets should be made in all clinically suspected cases with radiographic evidence of widened growth plate, characteristic epiphyseal and diaphyseal abnormalities, and biochemical evidence of high alkaline phosphatase and low phosphate. A few conditions with rickets.
বিএমডি করিস লো বিএমডি পাবি এপিফাইসিস এই তো
ডায়াবেটিসটা বাদ যাবে, ইনফিসিসটা বাদ যাবে।
ডায়াবেটিসটা বাদ যাবে।
So metaphyseal.
যে ফিচার পাওয়া যায় বিভিন্ন রিকেট সেটা অস্টিওম্যালাসিয়া পার্ট হতে পারে বা অন্যান্য জিনিস।
Yes, sir.
বাট নট টিপিক্যালি রিকেট। এটা মেটাফাইসিয়াল।
A few conditions with rickets may have low ALP and high phosphate. A number of conditions can clinically or radiographically mimic rickets, which can be differentiated from rickets biochemically or focused radiographic and or genetic testing. Yes.
এখানে আমরা কিছু কিছু রিকেট তো আমরা ক্লিনিক্যালিও তো আমরা ধর মেটাফিজিক্যাল টেস্ট অবশ্য শিওর হওয়ার জন্য আমরা একটু ডায়াবেটিক্যাল করি না এক্সরে করতে হবে এক্সরে আর ক্লিনিক্যালের পরে বায়োকেমিস্ট্রিও সবার করতে হবে ঠিক আছে ঠিক আছে আমরা প্র্যাকটিক্যালি করে দিই ঠিক আছে।
Now coming to rickets severity score, that is the Thatcher score. So radiography scoring method for assessment of severity of nutritional rickets. So originally it was created by Thatcher for nutritional rickets and validated for X-linked hypophosphatemic rickets. I am not going in details of this severity scoring. The pros are quantitative measure for radiographic feature, greater the score bodes the clinical presentation and helpful for radiologic follow-up. The cons are need all 4 limb X-rays, validated for phosphopenic rickets, but score is usually lower as they lack the lucency. So whether the recommendation is radiographic scores for severity classification in rickets like the Thatcher score are to be mainly used for research tools, although they can have some role in monitoring response for therapy and prognostication. So whether we should proceed? No.
না আমরা কি রিকমেন্ডেশন বানাচ্ছি না অ্যাপ্রোচ বানাচ্ছি? অ্যাপ্রোচ না
যদি রেকমেন্ডেশন হয় তাহলে তো আমাদের গ্রেডস অফ এভিডেন্স দিতে হবে। লেভেল অফ এভিডেন্স দিতে হবে।
কোয়ালিটি অফ এভিডেন্স, রেটস অফ এভিডেন্স,
তা
এগুলো আগে ঠিক করতে
এটাতে
হবে।
দাঁড়াবে না। এটা
তাহলে
দেখেই করতে
এগুলো
হবে।
আগে ঠিক করতে হবে, তাহলে তুই লেখা।
যদি এটা অর্গানাইজেশন থেকে যায়, হ্যাঁ ঠিক আছে, তাহলে এটাতে
সেটা
তাহলে এটাতে গ্রেডস অফ এভিডেন্স,
রেটস অফ এন্ড কোয়ালিটি অফ এভিডেন্স,
কোয়ালিটি অফ এভিডেন্স দিতে হবে।
দুটোই দিতে হবে, গ্রেড এন্ড কোয়ালিটি। সেটা এইভাবে বলা যাবে না, তুমি কোথা থেকে নিয়েছো আর তা কি, সেটা সিস্টেমেটিক রিভিউ থেকে নিয়েছো কি আরসিটি থেকে নিয়েছো, সেটা থেকে বলতে হবে।
খাটতে হবে, করা যাবে, করা
রিপোর্ট
যাবে।
থেকে নিয়েছো।
So this is the original paper from Thatcher.
না, অরিজিনাল পেপারটা এইটার রিসোর্সটা কি? র্যান্ডমাইজ কন্ট্রোল ট্রায়াল না মেটা অ্যানালিসিস নাকি
সেটা নিজেরা বসে আগে ঠিক করতে হবে, আমরা
আচ্ছা।
কোনটাকে কোন গ্রেড দেবো, কোন কোয়ালিটি হবে এভিডেন্স দেবো।
Level of evidence.
লেভেল অফ এভিডেন্স,
We have to search
এবং
for.
গ্রেডস অফ এভিডেন্স এন্ড লেভেল অফ এভিডেন্স তুমি দিতে
So this is the paper for 85, 1985.
একটার থেকে দিলে তো হবে না, তাহলে ওটা জিটিপি হয়ে যাবে। এখন নতুনটা দেখেছিস তো যে
এটা বলছি,
এভিডেন্স তলারটা
রিসেন্ট যে বুড়োসমা ট্রায়ালগুলো হয়েছে এক্স লিঙ্কড হাইপোস্পেনিক রিকেটে, তাতে এই স্কোরটা ইউজ করেছে এবং তারা সেখানে ভ্যালিডেট করেছে, করে বুড়োসমা ট্রায়ালে ইউজ হয়েছে। তো সেটা একটা আরসিটি ডেফিনেটলি। হ্যাঁ,
হ্যাঁ, তো তাহলে আরসিটি হলে ভালো, তো সেরকম যদি
সেটাকে দিতে হবে।
থেকে তাহলে তো গ্রেডস অফ এভিডেন্স উপর
শুধু
চলে
এটা
যাবে।
নিয়ে কথা হচ্ছে না, পুরোটা
পুরোটা
রিকমেন্ডেশন তৈরি করতে গেলে
রেকমেন্ডেশনেরও একটা
গ্রেড আর
গ্রেড আর লেভেল থাকে।
তাহলে স্যার আমরা কি রুটিনলি প্র্যাকটিস করবো এটা?
তাহলে তাহলে আমি বুঝে যাবো যে রুটিন করবো কি করবো না। এটা রিসোর্স দেখতে হবে, এটা
সিস্টেমেটিক রিভিউ, সিস্টেমেটিক রিভিউ না।
না, এটা সিস্টেমেটিক রিভিউ নয়।
না স্যার, এটা তখন 1985 তখন ছিল, এটা জাস্ট একটা রিভিউ ছিল।
is not useful in routine clinical practice, however it can be used as a research tool. মানে এইটা কিন্তু যে routine clinical practice এ ইউজফুল মনে করছে না সেইটা বলে দেওয়া বোধহয়
মানে সেইটা ফার্স্টে রাখতে হবে, তাই ল্যাঙ্গুয়েজটা শুধু ফার্স্ট।
এটা ক্লিনিশিয়ানের উপর ছেড়ে দেওয়া হচ্ছে, whether he should use it or not. So for classification proper, it's the calcipenic, phosphopenic and miscellaneous causes. We all know nutritional disorders of vitamin D metabolism. Phosphopenic FGF23 dependent and independent, and miscellaneous causes are RTS, CKD, hypophosphatemia and primary PhD. So recommendation, classification of rickets should be based on pathophysiology, and we should suggest classifying rickets into calcipenic, phosphopenic and other variants.
Arindam, is it calcipenic or calciopenic?
ক্যালসিপেনিক।
Calcipenic.
In several texts it is calciopenic. Okay. So okay, fine.
Other variants গুলো বল, other যে classification system আছে সেগুলো বল, IPTH. So this is just a very fast classification of calcipenic rickets. Nutritional vitamin D deficiency, it can be dietary deficiency or endogenous synthesis. Calcium deficiency, mostly diet related. Gastrointestinal malabsorption syndrome like celiac disease, bariatric surgery. Hepatobiliary cirrhosis and biliary fistula or atresia, pancreatic insufficiency. And disorders of vitamin D metabolism like hereditary defect or acquired like anticonvulsant use or renal insufficiency. So coming to the nutritional rickets, either because of vitamin D deficiency and or low calcium. Now coming to the vitamin D level. So we suspect nutritional rickets when 25 hydroxy vitamin D is less than 12 nanogram per ml, or 25 hydroxy vitamin D 12 to 20 nanogram per ml with associated calcium deficiency, and this is based on IOM, that is the Institute of Medicine recommendation.
স্যার এই জায়গাটাতেই মানে কোন অ্যাসে ইউজ করবো আমরা?
মেথড অফ মেজারমেন্টও লিখতে হবে।
স্যার ওটা তো আমরা এতে বলবো। So very fast, these are the hereditary vitamin D metabolism defect in hydroxylation, that is type 1. Type 1A is 1 alpha hydroxylation defect, type 1B 25 hydroxylation. Defect in vitamin D action, that is type 2. Type 2A is receptor defect, and type 2B is VDR RXR complex with VDRE binding defect. And gain of function mutation of the CYP3A4, that is type 3 with increased inactivation. So this is the VDR 1 where the impaired synthesis of 125 hydroxyvitamin D. So 125 hydroxyvitamin D level is low. Okay. So I think my part is here complete. So this is in a nutshell of all the vitamin D deficiency. So we are proceeding for the
আছে স্যার ওটা স্লাইড আছে আছে আমি দিয়েছি
so initial evaluation by Shobhadip Raman.
So after few initial recommendation for diagnosis, হ্যাঁ মানে IOM এর চারটা আমরা দিয়েছি। আচ্ছা এখানে একটা ছবি দিয়েছি সায়ন্তনদা, দেখো ছবি দিয়েছি যে রিফ্লেকশন সিরাম 25 হাইড্রক্সি লেভেল কার নিচে হলে বোন হেলথ খারাপ হয়, ওখানে 12 পর একটা শার্প ইনক্লিনেশন রয়েছে।
12 the level is almost
বলা মুশকিল, বাট ক্যালসিয়াম অ্যাবজর্পশন কমে যাচ্ছে, বিএমডি খারাপ হচ্ছে, একটা রয়েছে। কিন্তু রিকেটস, হ্যাঁ রিকেটস বোন অ্যাক্রিশন লেখা আছে, কিন্তু এটা IOM থেকে নেওয়া। IOM ইনস্টিটিউট অফ মেডিসিন ওয়াচ সেটা খুঁজতে হবে, ঠিক আছে। Let us proceed to the history part. So in a suspected patient of ricket, when we have diagnosed by the initial diagnostic criteria, we need to take proper history. And the history includes a lot of things. If I go through fast, age of onset, some rickets present at infancy, some at later age. Changes in severity, some of them have waxing waning course as I have written. ভিটামিন ডি রেজিস্ট্যান্ট রিকেট যেগুলো বা ডিপেন্ডেন্ট রিকেটটাকে যেটা বলতো, মানে একদম সিজার বা টিটেনি খুব কমন কি নিউট্রিশন সবকটা
ফিচার অফ ক্যালসিফেনিক রিকেট,
তাহলে ক্যালসিফেনিক। ওকে তাহলে ওইখানে হাইপোক্যালসিফিক সিমটমটা ক্যালসিফেনিক, ঠিক আছে। অ্যালোপেশিয়া অ্যান্ড লস অফ আইব্রো আর স্পেসিফিক্যালি মোর কমন ইন রিসেপ্টর মিউটেশনস VDDR2। হ্যাঁ জেনারেলাইজ হয়, লস অফ আইব্রোজ, লস অফ সবইয়ারই কমে যায়, জেনারেলাইজড অ্যালোপেশিয়া। Yes. Area of involvement, it has been seen calcipenic rickets are more involving the upper limbs, the phosphopenic involves lower limbs. Generalized pain, irritability, more in it depends on age of onset basically. Okay, ঠিক আছে। এজ অফ অনসেটের সাথে কি হিস্ট্রি নেবো তার টেবিলসে। এজ ডিপেন্ড, presentation. Okay. Benta?
এই লো ক্যালসিয়াম ভিটামিন ডি ইনটেক মানে কি কথাটা আমরা
But still, sir,
ক্যালসিয়াম খাই কিনা?
না অ্যাকচুয়ালি ডায়েটারি হিস্ট্রি নেওয়া দরকার, আমি স্লাইডটা হাইড করেছি। প্রত্যেকটা এজ গ্রুপে রেকমেন্ডেশন আছে আইএমের কতটা ক্যালসিয়াম নিতে হবে, 0 to 6 month 200 মিলিগ্রাম, 6 month to 1 year 260 মিলিগ্রাম, এরকম করে করে রয়েছে। তো প্রপার ডায়েটারি হিস্ট্রি ইজ ইম্পর্টেন্ট সেখানে।
তাহলে ডায়েটারি হিস্ট্রি
IOM এর সাথে একবার NIN এরটাও একবার দেখে দিই, যেহেতু আমরা
ইন্ডিয়া ওকে
NIN এর রেকমেন্ডেশনটা একবার দেখি।
আচ্ছা আচ্ছা
ক্যালসিয়াম ইনটেকের উপর ওই কাটঅফটাও ডিপেন্ড করে। ভিটামিন ডি বলা আছে যদি কম ইনটেক হয় তাহলে ভিটামিনটা আমরা ইউজুয়ালি
corticosteroids. Okay, okay. And for nutritional ricket, we have to inquire about the low calcium intake or inadequate sun exposure, some drugs like anticonvulsants, INH, features of malabsorption. So these things are more favor of nutritional ricket. Family history I missed. It's মানে ভিটামিন ডি ডেফিসিয়েন্সি রিকেট অ্যাকচুয়ালি, ডেফিসিয়েন্সি রিকেট না অ্যাকচুয়ালি কজের ইটিওলজির মধ্যে ডিগ্রুটে ওটা ক্লাসিফাইতে রেখেছে গ্যাস্ট্রোইন্টেস্টিনাল ভাগটা, মানে এই ক্লাসিফিকেশনটা যেটা দেখেছি সেখানে গ্যাস্ট্রোইন্টেস্টিনাল আর নিউট্রিশনাল ওরা আলাদা ভাগ করেছে, যদিও স্পার্লিং একসাথে আছে। তো জানি না এটা কি করব সেক্ষেত্রে,
লো ইনটেক
বুঝতে সুবিধা।
ডেফিসিয়েন্সি রিকেট কি সবটাকে এনকম্পাস করে? ডেফিসিয়েন্সি রিকেট কোনো অসুবিধা হবে? এটা কি একটা সবটাই
আচ্ছা তাহলে ক্লাসিফিকেশনে দুটো জুড়ে ডেফিসিয়েন্সি রিকেটস করে দেবো, শোনাতে দুটো ভাগ করতে হবে, ঠিক আছে ওকে ওকে ওকে। তাহলে ওখানে ওটাকে ডেফিসিয়েন্সি, হ্যাঁ হ্যাঁ সব ডেফিসিয়েন্সি চলে আসবে।
তো শুভদীপ
ডেন্টাল হুম হুম একদম একদম রাইট।
আর একটা পয়েন্ট শুভদীপ,
হ্যাঁ
অ্যানিমিয়াটা থাকবে না, অ্যানিমিয়ার হিস্ট্রিটা থাকবে না?
হ্যাঁ অ্যানিমিয়ার হিস্ট্রি অ্যাকচুয়ালি ওটা ফসফেনিকে ইম্পর্টেন্ট,
ইম্পর্টেন্ট এখানে এডিএইচআর এর ক্ষেত্রে ইম্পর্টেন্ট, তো
এডিএইচআর এর জন্য ইম্পর্টেন্ট অ্যাকচুয়ালি ওটা এক্সামিনেশনে রেখেছি অ্যানিমিয়াটা, ঠিক আছে। আচ্ছা এটা হিস্ট্রির মধ্যে হচ্ছে এগুলো, এছাড়া পলিউরিয়া, হিয়ারিং লস, সাম স্কিন ম্যানিফেস্টেশন ক্যান ইন্ডিকেট সাম ফিচার অফ রিকেট। সো আর দ্য পপুলেশন হু আর অ্যাট রিস্ক একটা টেবিল করেছি, এটা রিড আউট করছি না। তো রিকমেন্ডেশন হিয়ার ইজ হিস্ট্রি টেকিং ইন রিকেট শুড এম at identifying predisposing factor for vitamin D deficiency with a focus on diet and sunlight exposure, family history for inherited etiology, medication history, and specific non-skeletal manifestations pathognomonic of a particular subtype. Malabsorption. ঠিক আছে, এগোচ্ছি। ক্লিনিক্যাল এক্সামিনেশন we have divided in two parts. One part is features of ricket, we need to find it out, different areas can be involved, and among that one important feature is intercondylar and intermalleolar distance. It can be measured, but we exactly do not know what should be the ideal cutoff for saying it's elevated. Yes sir, so what we have found is at birth usually baby present with genu verum till 1 year of age. At 1.5 year the lower limb straighten. From 2 to 3 year genu valgum starts and gradually adopts the adult part, and by 6 to 7 year age the usual genu valgum is 5 to 6 degree. There is an UK data which have shown that between age of 2 to 11 years an intermalleolar distance of 8 centimeter and intercondylar distance of 3 centimeter and a genu valgum of up to 12 degrees is considered normal. ইন্ডিয়ান স্যার বাচ্চাদের পাইনি, একটা বড়দের ডেটা পেয়েছি, সেখানে ইন্টারম্যালিওলার ডিস্টেন্স দিয়ে দিয়েছে, বাট দ্য এজ গ্রুপ ইজ 20 to 40, দেওয়া যাবে না এটা। সো হ্যাঁ হ্যাঁ ছবি আছে স্যার, ওরা ক্যালিপার্স দিয়ে মেপেছে, মানে এই ইউকে স্টাডিটাতেই ওরা দেখিয়েছে ছবিটা,
ছবি আছে মানে কোথাকার ছবি?
মানে ওদের এই যে পেপারটাই তলায় লেখা আছে, যেটা দেওয়া যাবে না।
আমাদের নিজের ছবি তুলে দিতে হবে।
ওকে
এক্সাক্ট মেথডোলজি যত এবং এইটা এই জায়গাটা আমি যেটা দেখছি এটা একটু ক্লারিফাই করা কি কোন ডিসটেন্সে কিভাবে দাঁড়িয়ে
ওকে ওকে
ডায়াগনোসিসের কনসেন্সাসে আমার মনে হয় এই জায়গাটাই
ঠিক আছে। অ্যাকচুয়ালি দুভাবে মেজার করা যায়, একটা স্ট্যান্ডিং পজিশনে, একটা সুপাইন পজিশনে। মেথডটা আমরা লিখতে পারি এখানটা তাহলে। কিন্তু স্যার নর্মাল লেভেল কত দেবো তাহলে এখানে? ইউকে এভিডেন্স, এটা 22 সালের পেপার। ঠিক আছে।
স্ট্রেচারটাই তো আলাদা। নেই সেটা বলে দিন, নেই এটা
ইউকে ডেটা বলে। ওকে ওকে ঠিক আছে ঠিক আছে। তো the other part of clinical examination, it focuses on the etiology of rickets. So whether by examining we can have a clue. So for that we have some stature related, some bony change, some craniofacial abnormalities which are characteristic of some disorders, skin changes, hearing loss, ectopic calcification, anemia and urinary tract abnormality. I'm not reading all of them.
ইউকে ডেটাতে কি কোনো এশিয়ান সাবসেট ছিল, মানে পপুলেশনের ওই ওদের তো অনেক ক্ষেত্রে এশিয়ান সাবসেট থাকে,
রাইট রাইট,
সেটা আছে কি
পড়ে দেখিন দেখতে।
ওইটা হয়তো যদি এশিয়ান সাবসেট থাকে ওদের অনেক ক্ষেত্রেই,
তাহলে
উই ক্যান কোড দ্যাট বেটার।
ওকে স্যার ওকে। ওকে ওকে শোনা ওয়েল, সো ডেন্টাল ম্যানিফেস্টেশনটা আমরা আলাদা করে লিখেছি কারণ দেয়ার আর লট অফ ডেন্টাল ম্যানিফেস্টেশন ইন রিকেট, তো খুব ডিটেলসে যাচ্ছি না, এগুলো খুঁজে খুঁজে লেখা। সো দ্য রেকমেন্ডেশন হিয়ার ইজ ক্লিনিক্যাল এক্সামিনেশন শুড ইনক্লুড ডিটেলড স্কেলিটাল ইভ্যালুয়েশন অ্যালং উইথ ফোকাসড systemic including dental, ophthalmologic, cutaneous and otologic evaluation to identify pointers to a specific form of ricket. মানে স্যার ওটা ডিসকাশনে দিচ্ছি আমরা, বা টেবিলগুলো দিচ্ছি। হ্যাঁ Well, so coming to the initial biochemical evaluation and radiological, so these are the evaluation what we suggest should be done for all: alkaline phosphatase, calcium, phosphorus, creatinine, arterial blood gas analysis. ওকে ম্যাম, অ্যালবুমিনটা আসছি পরে। আচ্ছা ফসফরাসটা আরেকটা লাইনে করে দেওয়া আছিস, মানে ডিটেলসে আসছি স্যার, আসছি অনেক আছে, প্রত্যেকটা ডিসকাস করবো আমরা।
স্যার এবিজি কি করে আসবে ফার্স্ট লাইন অফ ইনভেস্টিগেশনে?
হ্যাঁ এখানে বাইকার্বনেট নেই, এবিজি এটা নিয়ে কনফিউশন হচ্ছিল। আলাদা পয়েন্ট, আমি আলাদাই ডিসকাস করছি, এখন নেই স্যার, ওটা আসছি। ওকে একটু এগোই তাহলে বোঝা যাবে।
স্যার
হ্যাঁ ওকে, সো দ্য রেকমেন্ডেশন ওইটাই আমি লিখেছি। শুনে তার এটা ফসফরাস। ওকে ফাইন, সো একটা একটা করে আসছি। ইনিশিয়াল ইভ্যালুয়েশন অ্যালকালাইন ফসফেটেস, দের ইজ ওয়াজ আ কন্ট্রোভার্সি উইচ ওয়ান উই শুড ইউজ, বোন স্পেসিফিক অ্যালকালাইন ফসফেটেস অর দ্য টোটাল। তো টোটালটাই ধরছি, বোন স্পেসিফিক ইজ নট ইউজ অ্যাভেলেবল এভরি টাইম। ইট হ্যাজ ইউজুয়ালি এ টেট্রাফিজিক রেফারেন্স রেঞ্জ, আই এম সরি ইটস নট রিডেবল আই থিঙ্ক, যে ঠিক আছে। And this alkaline phosphatase method should be in accordance with the International Federation of Clinical Chemistry, that is IFCC recommendation. So actually at a part of LFT আমরা পাঠাচ্ছি, যেখানে আমরা টোটাল অ্যালকালাইন ফসফেটেজ দেখছি, ওখানে বলছি উইথ এক্সক্লুশন অফ, হ্যাঁ না অ্যাকচুয়ালি টোটাল অ্যালকালাইন ফসফেটেজ যখনই নেব তাতে একটা তলার সাথে লাইন লেখা থাকছে উই হ্যাভ টু এক্সক্লুড আদার অ্যাক্টিভ লিভার ডিজিজ।
ফাস্টিং স্টেটে না
অ্যালকালাইন ফসফেটেজ এনি টাইম পাঠানো যায়। ওকে,
সেটা একটা ইনডাইরেক্টলি অন্য পারপাসে ফুলফিল করছে।
না রিকেট
ইনিশিয়াল ইভ্যালুয়েশনে তো লাগবে না, ইনিশিয়াল ইভ্যালুয়েশনে
কোন স্পেসিফিক তো দেখবো না, তো লিভার ডিজিজের টোটাল তো বাড়তে পারে।
এবার লিভার ডিজিজ যেটা এমন হতে পারে শুধু অর্গান ফসফেটেজ বেশি
অবস্ট্রাকটিভ হতে পারে।
এটা পুরোটাই ডিপেন্ড করবে ক্লিনিক্যাল কনটেক্সটের উপর। মানে কাউ গ্র্যানুলার ক্লোরাইড রয়েছে শুধু এলপি পারবে লিভারে, কারো একটা মাইল্ড ডিগ্রি অফ অবস্ট্রাকটিভ, মানে সবাই একটা পয়েন্ট যে মানে ক্রনিক লিভার ডিজিজ সময় তো ভিটামিন ডি ডেফিসিয়েন্সি হতে পারে, ক্রনিক লিভার ডিজিজ তো সেটাও আমরা পয়েন্ট একটা কাছে একটা জায়গায় যদি ইনিশিয়াল ইনভেস্টিগেশন এডিজি থাকতে পারে তাহলে ইলেকট্রিক মাধ্যমে তো কিছু নেই।
That may be influenced by liver disease. So as a part of it,
Lefty should be done.
It should be there somewhere in the text.
Okay, okay. So one caveat of alkaline phosphorus is that in India, in nutritional decade, often there is coexistent zinc deficiency. So associated zinc deficiency can have low alkaline phosphorus. এটা ডিসকাশনে থাকবে, আমরা লিখবো না, ডিসকাশন ওইটুকু থাকবে। তো স্লাইডটা পেরিয়ে যাচ্ছে। So calcium, coming to calcium, ionized calcium is our preferred one, and total calcium can be sent, but albumin connection I have not written, I am showing why. It's usually normal or low normal, and high calcium may reflect primary hyperparathyroidism or clotho-mutation. These two situations can have high calcium. Regarding the ionized calcium, its measurement is dependent on the pH of the sample. That is why the transport is very important. We have to send the sample in the syringe itself with the, you have to make sure no air bubble inside the syringe and the needle bent to avoid or minimize air entry. Okay.
Hypercalcemia can also be due to the over treatment with 125 dihydroxyvitamin D. So not only these two conditions, during treatment it can also appear. Though we are discussing about the diagnosis part, but যদি ওভার ট্রিটমেন্ট করি কাউকে 125 ডাইহাইড্রোক্সিভিটামিন ডি দিয়ে, বিশেষ করে হাইপোফসফেটেমিক ক্রিকেটে,
Then well, coming to the albumin correction controversy, traditionally we have been using the albumin correction, but there is a recent study from Norway, almost 20,000 patients, and they showed that the correlation of total calcium with ionized calcium is better as compared to the albumin corrected total calcium, and they have recommended that albumin modification of total calcium determination is unlikely to add valuable information, and this practice should be abandoned.
This is a very interesting study.
Yes, sir. এছাড়াও
আরো অনেকগুলো স্টাডি আছে ডিফারেন্ট পেশেন্ট পপুলেশন ইনক্লুডিং হেমোডায়ালিসিস,
স্যার ওটা
ইনক্লুডিং আইসিইউ, সেগুলো তো আগে ছিলই, এটা কিন্তু জেনারেল পপুলেশনের উপর এটা বড় স্টাডি আছে, মানে এখন মাল্টিপল এভিডেন্স আছে এবং মোটামুটি ওয়ার্ল্ড ওয়াইড রেকমেন্ডেশন আমি কিন্তু
দরকার নেই রেকমেন্ডেশন। ভুলে গেছি।
এটা কত বড় স্টাডি?
স্যার 20,000 পেশেন্ট, 20,000 পেশেন্টের সেটাই।
এখানে কিন্তু লেভেল অফ এভিডেন্সটা কোট করছে এবং দিস ইজ সামথিং
হ্যাঁ স্যার, 2016 সাল থেকে বেরোচ্ছিল, এটা 16 সালের স্টাডি। আর একটা পেয়েছি, যদিও ইটস নট ইম্পর্টেন্ট ফর রিকেটস, বাট হিমোডায়ালিসিস পেশেন্টের জন্য একটা কারেকশন ফ্যাক্টর নতুন দিয়েছে 0.18, মানে আগে আমরা যেটা 0.8 ইন্টু অ্যালবুমিন কারেকশন করতাম, তো এটা অনেকটা লো, রাইট। হ্যাঁ ওকে, আচ্ছা আচ্ছা আচ্ছা, ঠিক আছে। So our recommendation would be here, it's preferable to measure ionized calcium in serum, while serum calcium, total calcium may be sufficient in resource limited setting. Using formulas to calculate albumin corrected calcium values are no longer deemed necessary. Right, sir. I mean, look,
ডেটাবেস থেকে অ্যানালাইসিস করেছে, ওই ইনফারেন্সে ওরা কি করে এলো, ওরা ডেটাবেস থেকে বলছে কম্পেয়ার করছে কার সঙ্গে, কোনটা ভালো কোনটা খারাপ আনতে কি করে গোল্ড স্ট্যান্ডার্ড ধরে বাকি টোটালের সঙ্গে আর একটা কারেক্টেড ক্যালসিয়াম একটা, টোটাল একটা, একটা আয়োনাইজ থেকে গোল্ড স্ট্যান্ডার্ড ধরে
রাইট। সো স্যার, স্যার আয়োনাইজড ক্যালসিয়ামে হ্যাঁ স্যার আমরা অ্যাকচুয়ালি বলবো, এটা ইম্পর্টেন্ট, আমরা ফোকাস করবো, রাইট হয়ে গেল। Now coming to the phosphate part, it's usually sent in the fasting sample, the morning value. এই কাট অফগুলো প্রত্যেকটাই we have taken from the pediatric nephrology guideline published in 2022. When we check the cross reference, these values came from a Canadian study, the Caliper white paper study, where they have calculated the pediatric reference range for multiple parameters including calcium, phosphate, alkaline phosphatase and everything, মানে অনেক কিছু নিয়ে করেছে। So we may use this reference range. Right. So initial urine routine test and creatinine is very important to exclude renal disease, or if in presence of gross proteinuria or glycosuria, we should raise suspicion of Fanconi syndrome. Urine calcium creatinine will come it later, but again it should be done. Although I think it's not a initial test, we'll come to that later. Regarding the creatinine assay, the two most used methods are modified Jaffe method and enzymatic PAP method, but again both the method have shown more or less equal result. And importantly, we should correlate this result, correlate the assay with the standardized IDMS assay, that is isotope dilution mass spectroscopy assay. And most of our labs here now they use IDMS corrected or affiliated method to measure the creatinine. Sir, PAP method use হয়, Jaffe or modified Jaffe use হয়. So far what we have come to the approach, once the হ্যাঁ ওটা সার্চ করেছিলাম, হ্যাঁ বাট আমি রিসেন্ট যে আর্টিকেলটা পেলাম 23 সালে, সেটা আবার ডিফারেন্স নেই দেখাচ্ছে, তো দেখালাম, ঠিক আছে। Okay, so what we have done so far, once we have a classical triad of clinical sign, biochemical change and X-ray change, we diagnose it as a ricket. Next, we send the initial battery of test, which includes the calcium, phosphate, creatinine, vitamin D, urine RME, and arterial blood gas analysis. I'm sorry, the vitamin D is not written here, but if we find something abnormal, like the alkaline phosphatase is normal, calcium it is high, if there is presence of acidosis, high creatinine or high phosphate, we have to think of other causes of ricket, like I have shown here, calcium high in 2 situation, acidosis in renal tubular acidosis, high creatinine in CKD patients. So after this part, we have to go for the second tier of test. Here I have written the recommendation here. Presence of metabolic acidosis in blood gas analysis should raise the suspicion of renal tubular acidosis, which we'll discuss later. One confusion is, should it be an ABG or VVG should suffice? ABG. Well, না কারেক্ট করতে হয়। কোনটা? হ্যাঁ, সেখানে ভেনাস ব্লাড করতে পারি, পেরিফেরালি করতে পারি। ডিসকাশনে তো রাখতে হবে। ঠিক আছে স্যার, আমরা ইয়েতে যাচ্ছি। ভিটামিন ডি অলরেডি আই থিঙ্ক ইট হ্যাজ বিন ডিসকাসড, উইল কাম টু দ্য algorithm part later. What is important here, we have to ensure vitamin D sufficiency before going for a detailed testing. So it often happens that even a non-vitamin D deficiency ricket may present with low vitamin D. So in that situation, we have to first give vitamin D and we have to follow up the changes. The changes are sequence written here, and here we recommend that in cases of rickets, vitamin D less than 12. হ্যাঁ, মানে এইটা এক জায়গায় 2 weeks পেলাম ফসফেট নর্মালাইজেশন, আর একটা জায়গায় পেয়েছিলাম 2-3 days-এর মধ্যেই আবার শুরু হয়ে যায়। 4 days-এর মধ্যে লিখবো। ওকে ওকে, ঠিক আছে। আর পরেরগুলো আমি 3 weeks 2 to 3 weeks লিখেছি, সেগুলো টাইম। ওকে, recommendation is 25D less than 12 should considered as deficient, and they should be replaced with adequately oral cholecalciferol and calcium before proceeding for further evaluation. And now the definition of refractory ricket, it is defined as absence of radiological healing after some takes say 4 weeks, some say 6 weeks of oral calcium and cholecalciferol in appropriate dosage. মানে শুরু হয় 2 থেকে 3 সপ্তাহে, বাট কতদিনের মধ্যে না হলে রেজিস্ট্যান্ট বলবো এটা খুব শিওর নই।
ভিটামিন ডি রিপ্লেসমেন্টের জন্য তো 6 to 8 ভিটামিন ডি ডেফিসিয়েন্সি সাথে 6 to 8 তো মিনিমাম
রাইট
লাগবে রিপ্লেসমেন্ট।
এবার সেইটা কি শুরুর থেকে ধরবো না শেষের থেকে ধরবো?
শুরু থেকে, যখন রিপ্লেসমেন্ট
শুরু করব তখন থেকেই। ওকে, 6 weeks তাহলে ধরছি এটা। ওকে, the PTH, it's a prime step in differentiating calcipenic and phosphogenic ricket. Most of the guidelines, they recommend that calcipenic ricket PTH is markedly elevated. For phosphogenic ricket, it's normal or slightly elevated. But what reference range we should take? There is no difference cutoff for children, but it has been shown that in healthy children and adolescents, they cover a narrower range than the adult value. So possibly 15 to 45 is a good cutoff for parathermone. Now, how to send the blood? We can send it in 2 ways. We can send in clotted vial, where we should send without any clot chain. They need to clot in a room temperature. After that, serum is separated and should be refrigerated or tested. However, we can send in plasma. If we take the blood in plasma, then we have to treat it like ACTH. We have to send through cold chain, cold centrifuge, and test it as early as possible. This has been taken.
Actually, clot vial-এর জন্য 2 hours. Clot vial-এ কিন্তু এতে অনেকক্ষণ বেশি রাখা যায়, plasma properly carry করা যায়।
Right.
Yes. 96 hours অবধি রাখা যায়।
Yes. স্যার বেসিক্যালি এটা আমাদের ইমিউলাইট মেশিনের ইয়ে থেকে নেওয়া, বাট কিছু পেপার পেলাম যেখানে কিভাবে পিটিএইচ। ও আচ্ছা, ওটা 96টা নেই, 96 মানে আমি যেটা দেখালাম সেটা ইমিউলাইটের। হ্যাঁ, বাট এই পেপারটায় অনেকগুলো কথা বলেছে পিটিএইচ এসে নিয়ে, যে টাইপ অফ স্যাম্পল টিউব ওরা বলছে এই ডিটিএতেই নিতে, ক্লটেডের কথা রাখিনি, এবং সেখানে 24 আওয়ারের মধ্যে সেপারেশন ইজ রিকোয়ার্ড ফার্স্ট বলছে। 4 ডিগ্রিতে যদি আমরা করি 72 আওয়ার অবধি রাখা যেতে পারে 4 ডিগ্রিতে। সাইট অফ স্যাম্পলিং ইজ ইম্পর্টেন্ট, সেন্ট্রাল এরিয়া থেকে নিচ্ছে না পেরিফেরাল এরিয়া থেকে, অ্যান্ড অ্যাকর্ডিং টু দ্যাট রেফারেন্স রেঞ্জ মে চেঞ্জ। সিজনাল ভ্যারিয়েশন নিয়ে কিছু কথা বলা আছে, অ্যান্ড টাইম অফ কালেকশন হিয়ার দে রেকমেন্ড বিটুইন 10 AM to 4 PM the sample should be taken, so not at 8 AM. Again, this is an article from 2013. তো এর মধ্যে কতটা রাখবো আমরা?
তো ওইটা 10 to 16 hours যেটা 10 to সেটা উইক রিকমেন্ডেশন। রিকমেন্ডেশন ইজ ভেরি উইক। রিকমেন্ডেশন ইজ
রাইট উইক।
লেখা আছে উইক রিকমেন্ডেশন।
হ্যাঁ, এটা রিভিউ ছিল, সিস্টেমিক রিভিউ। হ্যাঁ, আমার 3-4টে স্লাইড আছে। Well, so recommendation is levels of serum PTH can differentiate between calcipenic and phosphopenic ricket, where markedly elevated PTH seen in most cases of calcipenic, where PTH is normal. না, we don't have a cutoff. স্যার কোথাও কাট অফ পাচ্ছি না আমরা।
এটা স্যার সব জায়গাতে বড্ড সাবজেক্টিভভাবে লেখা থাকে।
প্রাইমারি হাইপারপ্যারাথাইরয়েডিজম
না স্যার,
কোনো পাবলিশড লিটারেচার নেই।
হ্যাঁ স্যার, ম্যাক্সিমাম টেক্সটুকে কিন্তু এইভাবেই লেখা থাকে, সাবজেক্টিভভাবেই লেখা থাকে কথাটা।
পাবলিশড লিটারেচার নেই সেখানে। তাহলে এই রেকমেন্ডেশনে তাহলে রাইট।
তাহলে প্যারাথাইরয়েডিজমে প্যারাথাইরয়েড কার্সিনোমাতে প্যারাথাইরয়েড একমাত্র প্যারাথাইরয়েড কার্সিনোমাতে 1000।
তাহলে সেকেন্ড পার্টটা বাদ দিয়ে দিচ্ছি, ফার্স্ট পার্টটা শুধু রাখছি। মানে পিটিএইচ ক্যান ডিফারেন্সিয়েট বিটুইন ক্যালসিপেনিক অ্যান্ড ফসফোপেনিক রিকেটস, এটুকু
এটা পারে না, এটা পারে না
থাকবে।
স্যার yes sir, yes
ঠিক
very
আছে
important.
Okay, so we have gone through this approach. Here I have added IPTH, we have sent IPTH if it's calciopenic ricket or it's a phosphopenic ricket, but it's very important that it's not always possible to differentiate between these two with PTH value alone. So here the clinical clues are very important. From the history and the clinical examination we have got lot of clinical clues, and there we can apply those clinical clues sometimes to differentiate between calcipenic and phosphopenic. Now, once we have diagnosed it's a calcipenic, the next step is very few. We have to do an 125 dihydroxyvitamin D, which is mostly done in chemilumiноmetry assay, and there are reference range again published in the pediatric nephrology guideline. And here we recommend that for cases of calcipenic ricket without 25D deficiency or refractory to cholecalciferol replacement, a suspicion of VDDR should be made. Values of 25 hydroxyvitamin D and 125 hydroxyvitamin D can be used to classify the VDDR type in such cases. So here one point is important, even despite giving cholecalciferol full dose, if the patient do not respond, we have to again test vitamin D, because there are some situation where despite after replacement vitamin D level does not rise. Now, next slide I see. So once we have diagnosed calcipenic ricket, then two tests we should get done. One is vitamin D, one is 125 hydroxyvitamin D. Now vitamin D will either be normal or high because all the patient we have already treated, but there are some situation where vitamin D is still low, and among these both the subgroup will measure the 125 hydroxyvitamin D. Again it can be either low high or low high in all the 4 groups. Now come to one by one. If it's a nutritional ricket which is unlikely in this stage, there the vitamin D will be low and 125 vitamin D will be high. This why we have kept this, because this combination can present initially, but when we are giving this approach, when vitamin D is already given in nutritional ricket, usually vitamin D is not low. Sorry? Okay, rickets. Okay. হ্যাঁ তাহলে yes sir. No. Now the situation where despite giving vitamin D it's low and 125 is also low is seen in 25 hydroxylase deficiency or in VDDR type 3 where there is increased metabolism of vitamin D, that is now considered as a novel form of VDDR. Earlier when we were student it was used to be VDDR 1 and 2. Now we have a VDDR 3. There we can get this type of biochemical evidence. If the vitamin D is normal but still 125 vitamin D is low, then it's a 1-alpha hydroxylase deficiency, and both the things high can occur in receptor mutation like VDDR2 or sometime in calcium deficiency. So this is in nutshell the approach of calcipenic ricket, and this is the chart. Acha, ekhane nutritional calcium deficiency. So I made this for presentation, and this is same chart made for giving in the publication.
So cutoff of 125 dihydroxyvitamin D and
Yes.
the method?
Yes, usually done in chemilumiноmetry assay. Still we do not have the LC-MS assay, and age specific cutoff is there for 125 hydroxyvitamin D that is taken again from the pediatric nephrology guideline. Well, so I stop here. Now we'll go through the phosphopenic ricket. Over to Rajendra.
I will just skip the initial part, I think. Sir, the pathophysiology start, I will skip.
70%
Sir, the RTA we have kept, we didn't keep. Just short. So for phosphopenic ricket, sir, I will just keep the basic phosphate homeostasis. So this is we have kept for the manuscript. This is a single diagram for both the basic causes and the pathophysiology together. So grossly the causes can be divided into 3 groups. Very rarely intestinal cause of hypophosphatemic ricket, where rarely with that infant formula feed and some malabsorptive disorder. Most commonly the FGF mediated disorder and non-FGF mediated, mainly the renal tubular loss of phosphate. Among the FGF mediated, we have divided into 3 groups: increased production, reduced degradation and increased activity, and non-FGF mediated, mainly the specific receptor defect and Fanconi syndrome and RTA syndromes. And these I think we will skip, sir, because of these are the individual disorders in all the groups that we have divided. I think we'll other. So we'll. This is how to approach. I think this history and clinical examination. These slides has been already discussed by Dr. Shubhodip, and we have given a detailed for clinical as well as dental thing. And this is the key laboratory finding. Again, whatever the features we have mentioned, that is for the most of the disease involved in one particular group, not for all the disease. The classical diseases in hypophosphatic rickets, the common biochemical picture we will get, that is high alkaline phosphate and low phosphate for the whole of the phosphenic group. It can be divided in either the GI cause or the nutritional cause and the renal loss of phosphate. Among the renal loss, it can be either FGF23 mediated or non-mediated. In FGF23 mediated, the overall common biochemical picture will be high or normal FGF with low calcitriol and low urinary calcium. On the other hand, in FGF23 non-mediated group, the major biochemical pattern will be low FGF23 and high calcitriol and high urinary calcium. So with that in background, I will directly proceed with. This is variable, that will add. Sunetra, ওটা একটু add করিস। So we'll start with biochemical investigation. I think
So this is basically, I'll start with the recommendation which we have formed. To start off with the biochemical investigation of phosphopenic rickets, we need to evaluate first whether there is renal phosphate wasting. So for that, we go for estimating the TMP-GFR. Now, as of now, mostly in cases of adults at least, we have been using Bijvoet's normogram and also the algorithm given by Kenny and Glenn. But it has been seen that these are not very accurate in children. There is a tendency to overestimate the TMP-GFR when we use these methods to calculate the TMP-GFR. recent studies and the studies of Brodel et al. In 1988 and Stark et al. In 1984, they have devised another equation for which a TMP-GFR can be estimated more accurately, especially for children, which is given by the formula serum phosphate minus urine phosphate by urine creatinine into serum creatinine. A low TMP-GFR would indicate renal phosphate wasting due to FGF23 or other phosphatoinins. A high TMP-GFR in case of phosphopenic rickets is extremely rare and suggests malabsorption or a GI cause or a reduced dietary intake of phosphate.
Is it Amartya, is it high TMP-GFR, the last line, or it's normal TMP-GFR? So low TMP-GFR renal phosphate.
High or high? Normal or high? Normal. That is in the flow chart. We have given in the flow chart.
Fine.
ওটা তো ব্র্যাকেটটা কোথাও একটু গন্ডগোল আছে নাকি?
ঠিক আছে
পরেরটা এবার আলাদা করে আছে।
What the redent calculation has been mentioned in the recently published
JCM also.
Yes, JCM. But there are another calculation, online calculation.
Online calculators are available based on this calculation. They have made some online calculators which have made things much easier. Basically now online calculators are available where you can just directly put this data so that we can directly come out with the TMP-GFR, and the values of TMP-GFR which we get from the online calculators are actually the values which have been derived from this data itself, which I'll be presenting in the next slides. They'll just go back. Yeah. So basically we should have a overnight fasting sample. The first voided urine sample should be discarded. A 25 ml of second void urine has to be collected, and concurrent serum samples are collected. And this is again the formula which they have given. Now, we have a textbook teaching, and also we follow that we should go for a fasting sample to estimate TMP-GFR. These two studies, when they compared fasting and non-fasting samples, did not find any variation or any statistical difference in the TMP-GFR values, and hence they concluded that even if the patient comes from far-off places or patient coming with an OPD visit in the second half, these tests can be done and would not change much of the TMP-GFR value, and thus adding more to the convenience of this test.
Secondary hyperthyroid severe থাকে তাহলে TMP-GFR কিছু relevant?
Secondary hyper jara khub CFR থাকে, it'll TMP-GFR will be low.
For example, vitamin D deficiency. সেখানে
Phosphate low, TMP-GFR low হবে.
সেখানে যদি তো অনেক বেশি ফসফেট মানে IPTH থাকে, সেখানে তো ফসফেট এমনিতেই
low হবে.
No.
আমি একটা লেখা পড়েছিলাম যে TMP-GFR এর বেসিক অ্যাজাম্পশন হচ্ছে রিজনেবলি নরমাল PTH লেভেল।
অ্যালগরিদমের
PTH
মানে অ্যাপ্লিকেশনের উপর বেড়ে বলছি যে এই যখন TMP-GFR প্রথম ডিভাইস করা হয়েছিল, সেখানে যখন প্রথম ডিভাইস যখন দিয়েছিল সেটা তখন করেছিল টু ডায়াগনোজ
একদম
টু ডিফারেন্সিয়েট বিটুইন প্রাইমারি hyperthyroid and non-primary non-PTH dependent hyperthyroid সেটা non-PTH dependent hyperthyroid এটা PTH লেভেল মানে এটা তখন PTH ছিল না, increase PTH or একটা সারোগেট ছিল।
ঠিক আছে, এবার এটা যদি সেকেন্ডারি ভিটামিন ডি ডেফিসিয়েন্সি হয় IPTH বেশি থাকে।
Sir, correct sir. So before doing that equation, we have to rule out secondary causes of hyperparathyroidism.
Not primarily renal
PTH
এখনো ঠিক প্রশ্নতে আবার ব্যাক চলে যায়।
Now the point is whether we go for the term TMP-GFR or TP-GFR, because if you look at the earlier reports, they gave phosphate and looked at maximal phosphate reabsorption. So in this case, are not giving phosphate supplement. So this should be called as TP-GFR, not TMP-GFR.
So the original paper from which this formula was derived, they had mentioned that this is actually TP-GFR. Then in the subsequent studies which have been done, TP-GFR is the reabsorption of phosphate, TMP-GFR is the maximum reabsorption of phosphate. It has been seen in children, fasting children, it is already maximally reabsorbed. So we did not give to extra phosphate load is not needed in children. So whatever the TP-GFR is actually the maximum হ্যাঁ সেটা টেক্সটে মেনশন করা আছে, সেটা টেক্সটে মেনশন করা আছে।
applicable when secondary causes of hyperparathyroidism is ruled out. এই কথাটা তো লেখা দরকার।
না এই কথাটা কিন্তু আবার অন্যরকম আপত্তি আছে, সেটা হচ্ছে TMPGFR তো আমি প্রাইমারি হাইপারপ্যারা না সেকেন্ডারি হাইপারা দেখছি না। I look at renal loss of phosphate or non-renal loss of phosphate. So whether it's because of primary hyperparathyroidism কিন্তু renal loss of phosphate. হ্যাঁ। This is stimulated or not? না 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 স্যার। মানে তুমি যে কোনো কাজে যদি না তোমার টিউবুলার লস না হয়, তারপর হাইপোথেটিক্যাল তুমি বলছো যে এটা ভাইটামিন ডেফিসিয়েন্সি না প্রাইমারি হাইপারপ্যারাথিরয়েডিজম কম। সেই ফসফেটটা কম ডিউ টু রিনাল লস। রিনাল লস কিন্তু প্রাইমারি রিনাল না, আমি তো প্রাইমারি বলছি না। উই লুক এট রিনাল ভার্সেস নন রিনাল, প্রাইমারি বলছি না।
আমরা যদি মানে if you already have diagnosed secondary hyperpara, we will go into the treatment. হ্যাঁ, তখন আমরা TMPGFR এ এগোবো না, মানে সেই দিক থেকে ব্যাস সেটাকে।
না না স্যার, এই পার্থক্য ইউরিন কালেকশনটা কি সেকেন্ড ভয়েড না টাইম ভয়েড কালেকশন?
টাইম ভয়েড was
second void.
the again
Both can be done, but second void হচ্ছে
timed.
হ্যাঁ
ব্লাড না সেটা বলা আছে।
Again, the confusion is again there because of using the Beach-Boys normogram data. According to Beach-Boys normogram, they had collected the timed urine collection for their calculation of TMPGFR. Newer calculation doesn't. They went a spot sample of the second void urine. That's why this calculation equation is probably more convenient.
দুটোই দেওয়া থাকে
কিন্তু না
আচ্ছা
spot sample. But ওরা বলছে চিলেনের জন্য these are the points which are advantages in this equation, doesn't require a timed is one of those.
আচ্ছা আচ্ছা
Okay, so once we have done the TMPGFR, and then we decide if the TMPGFR is normal or high, then probably it's a non-renal cause, which is rare. Acha,
severe nutritional phosphate deficiency, the phosphate is around 1.5, say for example. So how does TMPGFR help?
Yeah, it will be zero. So that is a fallacy which I have kept it later. Basically, in those cases, if urine phosphate is also low and the TMPGFR is also low, we have to establish whether the phosphate intake, phosphate absorption, or the deficiency has been corrected. Only after correction of phosphate deficiency, then only we can proceed.
Discuss that.
I have given in the text, but not here. Text e lekha ache. যেখানে low value পাবো। Okay, and another aspect of method of estimating the renal phosphate loss is a fractional excretion of filtered phosphate, which again, sir has pointed out, we don't have enough evidence, or the level of evidence may be low, but it's mentioned in some of the papers. This is an alternative to estimating TMPGFR, which is cumbersome, the calculation is difficult, a lot of things are involved. It is a simple calculation where urine phosphate into serum creatinine divided by serum phosphate into urine creatinine multiplied by 100 gives us a percentage value, which is actually the fraction of the filtered phosphate, the amount of phosphate which is going out in the urine. If I come to the interpretation, as you can see, fractional excretion of phosphate of less than 20% indicates appropriate low urine phosphate excretion, which is normal. A fractional excretion of phosphate of greater than 20% indicates renal phosphate wasting. So this probably can,
We propose to keep both together, like in the flowchart.
Yeah, that is, yeah, that is something which we still don't. Doesn't recommend. Still not enough evidence to suggest for or against. Accepted. ঠিক আছে. So going back to the flow chart.
মানে ফ্লো চার্ট থেকে এটা বাদ দিয়ে দিচ্ছি মানে ফ্র্যাকশন আর এক্সপ্রেশন নেক্সট উইক
আচ্ছা. So if the TMP GFR is low, then the next step would be probably to see at the FGF23 levels. Probably we are dealing with something related to FGF23 dependent hypophosphatic rickets. Now coming to the recommendation regarding FGF23, phosphopenic rickets are classified as FGF23 mediated or non-FGF23 mediated. However, in resource limited settings, further evaluation in phosphopenic rickets may proceed without FGF23 measurement. If FGF23 is measured, we usually go for measurement of intact FGF23 by immunoassays which are recommended. I'll just briefly discuss the immunoassays. এটা কি এখনই বলবো? এটা পরে এটা ছেড়ে দেই। আচ্ছা, ইনটেক বডি ছেড়ে দেবো। হ্যাঁ ঠিক আছে, 9 minutes. হ্যাঁ, so almost done. I'll just skip this part. This is basically a sandwich assay detecting either the intact fragment or the C-terminal fragment of FGF23. But we usually we recommend intact fragment, intact IGF23 estimation for estimation of FGF23 by CLIA. There are all total around 12 assays which are worldwide available. Out of them, if you can see, only 2 at the bottom are CLIA, and the diazorin is available in our country for measurement of FGF23 by CLI. It is done in the most reputed labs in the country. Picogram per ml. এটা if I না কালেকশন ঠিক আছে। সো একটা কথা জাস্ট বলার, so we do not, there are different reported units. One is the picogram per ml of intact and another is a reference unit per ml of CFG23. As of now, no international standard for intact IGF23 is available. Therefore, it is not possible to standardize the assays and harmonization of the assays has not been done. So it is recommended to use assay-dependent reference values for IGF23. For example, those studies which have used kinase assay, they have used a cutoff of 30. Diacerin assays, I'm just quoting the lab, Lalpath and Metropolis are doing by diacerin. We are doing it by CLIA, and their cutoff range is 23.2 to 95.4. This is the assay-dependent cutoff range which we have to take because there are no standardized reference level. NG per ml. So pitfalls এখন আর যাচ্ছে না, pitfalls গুলো. So I'm going back to the okay, just going back to the flow chart from where we take it now. Okay, after SGF23 estimation, Rajan.
So if the assay cannot be done because of financial constraints or lack of infrastructure or whatever, so what are the options available?
So in the resource poor setting, we have thought of that can we use the other two commonly done marker in the form of urinary calcium creatinine ratio, calcitriol and PTH. So these are the 4 tests that can differentiate between FGF23 mediated or non-mediated when FGF23 is not assayable. However, they are correct for majority of the causes which has been classified under the FGF23 dependent and independent, but not for the all, but for the majority, like, sorry. So, no, sir, that's right. That's why, although low calcitrol serve as a good surrogate FGF23 mediate cause, but robust and accurate calcitrol analysis is not widely available. So that's why we have only urinary calcium creatinine ratio. Whether this in combination with the PTH, it can give us a surrogate hint in differentiating FGF23 mediated and non-mediated cause. Because
non-reliable. না পয়েন্ট হচ্ছে HHRH, সে ফর এক্সাম্পল, হ্যাঁ পারবো সেটাই প্রবলেমেটিক।
Ajitesh, the calcitriol assay is also not standardized. Calcitriol assay is also not standardized.
No. What are the possible non-FGF23 mediated hypophosphatemia if you rule out RTA? NAPI2 and NAPI2C defect. Right, so you get more higher calcitriol, you get suppressed PTH.
HHRH. That is NAPI2.
না আমি RTA বলে দিয়েছি। আমি তো বলছি সাপ্রেসড পিটিএইচ।
And regarding PTH, like what will be the consensus? Because it is also true, because whatever the disease we have, that is our first choice. That is our first choice. Okay. So we'll go to the next part. Once it is FGF23 dependent, then only thing we can do a routine urine examination. If there is, in addition to hypercalciuria, some evidence of proximal tubulopathy in the form of amino aciduria or normoglycemic glycosuria, then Fanconi syndrome and related disorder will be the most common etiology. And if there is no associated amino aciduria or hypercalciuria, then mainly the tubular defect in specific to NAPI2 and NAPI2C and NHRF defect. And after that, once we are having some basic classification depending upon the FGF23 and renal loss, further evaluation is only possible by the genetic analysis. So we have recommended, once the required acquired cause of rickets are reasonably ruled out, genetic analysis to identify inherited disorder is indicated, is particularly important for hypophosphatic ricket and RTA. Whether to go for a next generation sequence for the or a panel test or a specific gene test depends upon whether we are getting any specific clinical cues during the clinical examination. And lastly, we have kept post, because the TIO is extremely rare in children, so if post, even if there is no yield after a genetic testing, then we should search extensively whether we are missing any FGF23 mediated mesenchymal tumor related cause if the FGF23 is high. And this is in nutshell the overall approach that is for the manuscript. Sorry. RTA we are skipping then. So this will be the two summaries, and I think this is fine. Okay.
এবার স্যার এখনো খুব ভালোভাবে এখনো স্যার দেখিনি এবার যেটা করা হয়েছিল তারা এটা নেবে কিনা জানি না এখানে রিপোর্টে
Thank you all the members for valuable input regarding diagnosis and diagnosis of rickets and all the speakers. By this, I conclude the session.
To the beautiful Dhanodhanna Auditorium on this day of July 2023. This pre-conference workshop will mark the unofficial beginning of CRESCENDO, which is slated to begin tomorrow and will be inaugurated today late evening. For this pre-conference workshop, we have lined up 3 interactive areas of interest for endocrinologists in particular. Our 3 sessions will be on blood gas analysis, polysomnography and genetics. As is customary, workshops will primarily be interactive and all attendees are expected to interact with our faculty. You can ask questions or doubts whenever you want. We have allotted 1 long hour for each of these talks primarily to accommodate everyone. To begin this, I would like to invite on stage Dr. Chandrashis. Dr. Chandrashis happens to be my senior from Medical College, so Chandrashis Da will take us, he is a renowned critical care specialist of town and he'll take us through blood gas analysis and the various applied aspects as we encounter in our practice. Chandrashis Da.
First of all, I think I'm audible, right? Yeah. So first of all, thank you to the Endocrine Society of Bengal and Parthoda in particular for inviting me to in this beautiful session. I'm really very delighted to see this beautiful arrangement today and the conference hall as well. The first thing I'd like to say is, as Pankaj mentioned, that I'm really not an endocrinologist, neither am I from this field. So I usually practice intensive care, that's my bread and butter. And I've been asked to talk about blood ABG analysis. But Parthoda was rather particular that for me to discuss more of acid-base balance, which is probably more relevant to you. So, because of paucity of time, I will avoid discussions on oxygenation status and other respiratory issues, because that will be another section. So I'll basically try to concentrate on acid-base problems. Yeah. So can I start? Okay. So at acid-base balance, we'll do a little bit of, we'll mainly go by a case-based kind of a discussion. And with each case, we'll discuss a little bit of the ABG rather than doing a didactic of the ABG at first, because that becomes a little bit too much heavy and This is almost a post-lunch session. Everyone had lunch, I think. So it will be difficult for you to stay awake if I go that way. So let's start with the scenario where let's imagine that you are at home and you get a call at night from a ER physician that somebody has come, a patient has come, and this and the ER physician basically has called you so that he wants to know that I will go ahead to intubate this patient and ventilate this patient because he is very afraid that the pH is very low. You know, the pH is 7.1. That's pretty low, and the PCO2 is 50. Bicarb is also low. PCO2 is high. So he wants to intubate this patient. He's afraid that this patient will probably crash in a few more minutes. So anybody from the first table, what will be your response to this? Are you worried or you're not worried? Is pH 7.1 bad, ugly, okay, good? What do you think? Bad. Good. So any pH less than 7.2 is called severe acidosis, right? So it's bad. Fair enough. Is it bad enough that this patient should be immediately intubated? Maybe yes, maybe immediately intubated. But do you actually think that, looking at the whole thing, are you actually worried about this patient? This patient is otherwise verbalizing. This patient is a little tachypnic, but otherwise verbalizing, maintaining blood pressures, has got a history of fever, maybe some pneumonia. So this is the whole scenario. So whenever we talk or we get an ABG, the first thing is, especially in our country where we don't have a separate department to, you know, always cross-check the quality of each machine, you know. So the first thing is to find out, is this ABG valid or not? Okay. So how do we know? So this is a equation, the one on top, which has been derived from the original Henderson-Hasselbalch equation, but it basically says if you divide the PCO2 by bicarbonate and multiply it by 24, you should approximately get the H plus ion concentration. And the pH and the H plus ion is related somewhat like this. Somewhat like, is there a pointer here? No, right? Okay. Yes, yes. So if you see, let's look at 7.40, then the H plus is 40. If it is 7.3, the H plus is 50. If it is 7.5, then the H plus is 30. So basically, if you subtract the last two digits of the pH from 80, you will approximately get the H plus. This is not valid in the extremes, that is at 7.1 or at 7.7. Okay, thank you. I don't think it shows on the screen. Anyways, but otherwise it is valid. So even if you forget about this table, that is fine. Approximately, if it is 7.30 pH, the H plus concentration will be around 80 minus 30, that is 50. If it is 7.5, the H plus concentration will be 80 minus 50, that is 30. If it is 7.4, it will be 80 minus 40, that is 40. Did you get it? Okay. So in this ABG, if you go back, you will find that if you subtract, if you divide the PCO2 50 by 20 and multiply it with 24, your H plus will come somewhere around 60. So the pH cannot be as low as 7.1. Okay? So this patient's ABG is faulty. What is the commonest cause of a lower pH than is actually showing? It is because there is excess heparin in the syringe. Okay? So that is one of the commonest causes. The other can obviously be that the machine is not calibrated. So that should be your response, that the ABG doesn't look to be right. Now, do you think I will calculate this at the middle of the night? No. It is just by seeing maybe few hundred ABGs, it will automatically strike you that if your PCO2 is around 50 and your bicarb is around 20, your pH cannot be this low. Okay? So, but the logic comes from here. Do you need to do an ABG in all patients? In many situations, you might not need to prick the artery, because that is itself a skill to take an ABG to prick an artery, whatever it may be. It may be radial artery, it may be femoral artery, or something else. But most of the time, unless you are interested in the oxygenation status, you can probably do with a venous blood gas as well. The difference between venous blood gas and arterial blood gas is approximately 0.03. So if the pH in ABG is X, in VBG it will be 0.03 less. Similarly, for the PCO2, in the VBG it is approximately 4 millimeters of mercury more than the ABG. Okay? So this is an approximate relationship. Again, in extreme situations, in critical patients, these relationships always do not match. What about temperature? So temperature is something that we should know a little bit, because all ABGs are analyzed at 37 degrees, okay? So if somebody is severely hypothermic, their CO2 and oxygen is actually lower and the pH is actually much higher. If the temperature is more than 39 degrees Celsius, that is you're very hypothermic, then your carbon dioxide and oxygen is actually higher than the measured and the pH is lower. So interpretation of this fact is controversial, but the good news is that in most of the cases, this only becomes relevant to us in case of only certain situations where we take blood gas of patients who are severely hypothermic, like that happens in cardiothoracic OT. So if suppose the surgeon wants to go for a deep hypothermic cardiac arrest, in that case this kind of pH stat and alpha stat measurements are relevant. So for most practical purposes, you can assume that you don't need to correct your ABGs for the temperature of the patient. Okay? Now we'll start with cases. So first one. Now this is a very short history will be there, because our focus is mainly on the ABG and what we can find from that. So this is a middle-aged man who was recovered from home. He was found unconscious in a pool of vomit. The pH is 7.34. So if the pH is 7.34, it means less than the normal range, right? So our normal range is between 3.5 and 4.5. So less than the normal range, which is basically means there is acidemia. So whenever there is acidemia, the second thing is what is the respiratory status. The first thing that we see is what is the respiratory status, because the respiratory variables or the respiratory changes are less complex than the metabolic components. So here you will see that the carbon dioxide is above normal. So it's above 45, so 35 to 45 is normal, so it's above 45. So above normal, and therefore this is respiratory acidosis. Is this clear till now? So it's acidemia. The second question you ask is what is the respiratory status? The respiratory carbon dioxide is high, so there is respiratory acidosis. Now, next thing we look at is what is the bicarbonate. So bicarbonate is also high, which is expected because your body is supposed to compensate for a respiratory acidosis. So bicarbonate is high. The question is how much compensation is expected. So for every 10 millimeter of mercury rise in carbon dioxide, this is, we are assuming that this is an acute rise because the patient is now unconscious and found to be unconscious, and therefore the carbon dioxide has gone up acutely. So for every 10 millimeter of rise in carbon dioxide, bicarbonate increased by 1. So here, if you take normal carbon dioxide is 40, so 64 minus 40, that is 24. You can divide by that by 10, so 2.4. So 2.4 will be, the bicarbonate will increase by 2.4 above 24, which is the median number. So the bicarbonate should have been here 24 plus 2.4, 26.4. However, you find that the bicarb is 34. So what is happening here? So there is another metabolic alkalosis which is present, right? So this patient now has two problems. One is respiratory acidosis because the patient was really not breathing well, and the second is metabolic alkalosis. And what do you think is the common cause for it? The vomiting itself. Okay, the vomiting is itself a common cause of metabolic alkalosis. So the common cause of metabolic alkalosis are vomiting, which is one of the most common causes, and the second that we do in the hospital, nasogastric suction and nasogastric aspiration. Okay. The second group are drug induced, which are because of over-enthusiastic administration of diuretics, mainly loop and thiazide diuretics, which causes volume contraction alkalosis. The volume contraction alkalosis may happen from other causes also. You can have metabolic alkalosis from calcium supplements or oral soda bicarbonates. And in our country, there are patients who take betel nuts, and with betel nuts they use calcium salts. So if somebody is using in large amounts, that itself can be a source of alkali. And then again you have your mineralocorticoid excess, cortisol excess, and Barter's and Gitelman syndrome. Okay, we'll come to this later. So let's divide it into two groups. One is metabolic alkalosis because of contracted extracellular fluid volume. Okay, so whenever you have a contraction of the volume, you divide it into again two groups, whether your urine chloride is low or urine chloride is high. Urine chloride is not a great thing to be checked in emergency or ICU setting, because there are many things which will change it, alter it, depending upon the drugs and the fluids that you have given. But it is good if you are doing it in a patient who is relatively stable, either in the ward or has walked into the OPD. So if your urine chloride is low, which basically means your kidneys are fine, so there is loss of gastric juice like vomiting, nasogastric suction, remote use of diuretics, post-hypercapnia, metabolic alkalosis, we'll come to this, what it means, and loss of sodium chloride in the GI tract like congenital GI loss, villus adenoma, etc. The other option is when your urine chloride is persistently high, that is more than 20. This happens, this persistent high is very important. That means it has to be documented more than once. Okay. So it basically happens in Barter's-Gitelman syndrome or current diuretic use. Okay. The second group is the expanded ECA volume, where there is a large reduction in GFR plus a source of bicarbonate. This basically happens when your renal failure patients are taking a lot of alkali. So it can happen because you are giving them alkali tablets in the form of sodium bicarbonate or some other source of alkali ingestion. But remember that the kidneys are very good with getting rid of alkalis or bicarbonate. So usually if your GFR, unless your GFR is low, your body again corrects it very quickly. The other option is enhanced mineralocorticoid activity, either primary or secondary or endogenous or exogenous mineralocorticoids. Okay. I'm sure you know these things better than me. Potassium and alkalosis. Okay. So the third thing is that depleted extracellular fluid volume causes increase in aldosterone and kaliuresis or loss of potassium in the urine. So when the potassium is high in the lumen, there is less ammonium being reabsorbed because of the competition between ammonium ions and potassium. And with hypokalemia, more ammonium is reabsorbed and then secreted as ammonia combining with H+ and raising the bicarbonate in plasma. So hypokalemia causes metabolic alkalosis by a shift of sodium and H+ inside the cells, causing intracellular acidosis. To make this thing a little bit clearer, I'll just try to again show this picture. This is a very important cartoon which shows the kidney's role in acid-base balance. If you so the first thing happens in your proximal convoluted tubules, where there is an absorption of sodium, and always remember that the whole body and the whole of this blood gas discussion that we will do today, one very important golden rule is maintaining electron neutrality. So whenever there is a positive ion going in, usually it is balanced by another positive ion coming out, or another negative ion moving along with it, so that the electron neutrality is maintained. So here again you will find that there is absorption of sodium and bicarbonate in the proximal convoluted tubules, and this is augmented by angiotensin II, low pH, low potassium, etc. Second, you will find that there is an active transport of sodium potassium 2 chloride in the thick ascending limb, and this is inhibited by your loop diuretics, causing the alkalosis. Again, in the early distal tubule, you have a sodium chloride co-transporter, which is inhibited by your thiazide diuretics. And then a lot of thing happens in the collecting ducts. So these are not active transports, but these are passive exchanges between potassium and H+ being secreted into the collecting ducts in exchange of sodium. And this is promoted or augmented by aldosterone. Similarly, if you have a very low potassium or hypokalemia, it will do the opposite. That is, it will try to conserve potassium and secrete more of H+. So there is aciduria because of H+ secretion into the kidneys, and because of that there will be alkalosis, right? So hypokalemia itself can cause alkalosis. Your loop and thiazide diuretics by other mechanisms are causing alkalosis, and then you have the hormonal factors like aldosterone, etc. I'll come to that in another cartoon which will be a little bit more evident. Now this is a patient who has episodes of abdominal pain, a young lady, and profuse diarrhea for months. More recently, she has vomited on occasion and has suffered from episodic tingling and weakness, and he took antacids to relieve his abdominal pain, but their beneficial effect was transitory. Each time his condition reverts to normal without therapy. Okay? This is these are certain parameters which are being given to you. So on admission, people did not check their pH and PCO2, but the bicarbonate which was sent in the lab, from the lab, came back very high, around 62. Potassium was 3.1, and iron gap was 15, creatinine was 2.3. 4 hours later, when an ABG was done, the pH was still high, 7.5, PaCO2 was 48, bicarb 48, potassium slightly more, and an iron gap of 13. So, what do you think is happening here? Anybody, any idea? So obviously there is, the first thing is, again, we go by our rule book. That is, we look at the pH first. So the pH is high. So this is alkalemia. 7.5 is alkalemia. Okay? The second thing is, what is the PCO2? The PCO2 is also high. So high PCO2 does not contribute to alkalemia. It should cause acidosis, right? So that means this is not the primary problem. The primary problem is the bicarbonate, which is high. So here again, it's a metabolic alkalosis, and the PaCO2 is high either because of because of a respiratory condition or because of compensation. So how do you know? Now there will be formulas to know, but for now I'll give you a very simple bedside rule. The simple bedside rule is, in case of metabolic acidosis and metabolic alkalosis, your last 2 digits of the pH is approximately equal to your PCO2. So here the last 2 digits are 50, which is approximately equal to 48. That means the body is appropriately compensating for the metabolic alkalosis with a respiratory acidosis. So there is no other respiratory problem here. It is just a compensation, okay? And the bicarb has now come down. There's a little bit of renal impairment. Now this renal impairment, you will find, will come back to you time and again whenever you're dealing with very significant metabolic alkalosis. And the reason is that kidneys are usually very efficient to deal with chlorides and bicarbonates. So whenever there is a relative insufficiency on top of another problem, then it becomes manifested. So this renal insufficiency will keep on coming back with metabolic alkalosis. So this patient was suffering from something called a Zollinger-Ellison syndrome, causing excessive vomiting. So excessive vomiting causing metabolic alkalosis in this patient. Another case, 26-year-old dancer complains of weakness. She denies vomiting and any intake of other medications other than vitamins. She's otherwise a thin woman who has a contracted extracellular fluid volume. That means does not look to be very fluid overloaded. This is again the plasma parameters and the urine parameters. So here the sodium is 133, potassium 3.1, chloride of 90, bicarb 32, pH 7.48. So this is the next step. The next step is, you now know this is metabolic alkalosis. So as I told you, metabolic alkalosis with contracted ECF volume, you have to look at the urine chlorides and the urine. So what is the urine chloride here? Urine chloride here is 0. 0 means there is no problem with the kidneys, right? So chloride is low in urine because the ECF volume contraction and reabsorption of the sodium chloride. The sodium is high in the urine because it is excreted with an anion other than chloride. So the sodium here in urine is high. So if the sodium is going out, that means it is accompanied by something else, which is not measured here. This is bicarbonate. Okay? The very high urine pH indicated that the other anion is bicarbonate. So the pH of the urine here is very high. So the other iron here, the other ion which is going with the sodium is bicarbonate. Okay? And why is it happening? It is happening because the filtered load of bicarbonate exceeds the tubular capacity to reabsorb it. Okay? So what can this be? What may be the problem with this lady? Sorry? Proximal tubular dysfunction. There is, you see the urine chloride is here normal. So this lady has got a body shape disorder which is causing induced vomiting, and therefore she never gave a history of vomiting. What is the management for metabolic alkalosis? Well, the first thing is find out what is the expected PCO2 for the bicarbonate level. Because if suppose this patient is on a ventilator, then if you hyperventilate that patient, that will cause more of alkalosis. So do not hyperventilate. Second is saline, particularly if the patient is chloride responsive. Chloride responsive basically means that your urine chloride is low or less than 20. Second is acetazolamide, usually used for conditions where the urine chloride is high or saline, not saline responsive. If the patient has got a lot of NG aspiration because of intestinal problems, then you can try to give a proton pump inhibitor which will reduce the H+ secretion. Potassium replacement is important, particularly in a persistence of hypokalemia, because hypokalemia, as I showed you, is going to perpetuate metabolic alkalosis, and you identify other endocrine disorders. Okay, next blood gas. A COPD patient suddenly comes to the hospital because of desaturation, that is low oxygen, hypoxic and tachypnic. The pH is 7.50. So acidemia or alkalemia? Alkalemia, right? PCO2 of 48. So is it respiratory alkalosis or metabolic alkalosis? Metabolic alkalosis, because although the PCO2 is high, it cannot contribute to the primary problem here, that is alkalemia. So their metabolic alkalosis is the primary problem. We'll have to find out whether PCO2 is appropriate or inappropriate. That is a second question. Okay. The bicarbonate here is 36. Okay, and we find that the bicarbonate has almost remained the same from an old ABG. What does that mean? That means this patient is a chronic CO2 retainer, right? So a chronic CO2 retainer having a high bicarb, because that is how the body has compensated. So what is the compensation? The compensation is usually 40, which is the median PCO2, plus 0.7 times the change in bicarbonate. So the change in bicarbonate here will be calculated from 24. So 36 minus 24 is how much? 12, right? So 0.7 into 12 plus 40, 48.4. So that is what is the expected carbon dioxide. And what is the carbon dioxide measured? 48. So that is almost okay. So you can, the numbers will be like plus minus 3, right? That is acceptable. The other quick trick that I told you is that in metabolic and acidosis and alkalosis, you can take these two numbers, which are the last two digits after the decimal point, and the carbon dioxide is approximately equal to this. So 48 and 50, approximately equal. So that is usually valid unless in extreme situations. So there is appropriate compensation, fine. Now what is the next thing? The next thing is you can also look at the anion gap. The anion gap is sodium minus chloride plus bicarbonate. That is called the anion gap. You can add potassium to it, but because potassium number is usually negligible, so we don't add it. So sodium minus chloride plus bicarbonate, which comes around 10. So 10 of anion gap is normal or abnormal? Any idea? That is normal. Fine. So why is there a metabolic alkalosis when a patient has respiratory distress? So the golden rule of compensation, so you have said that this patient is a chronic CO2 retainer. So primary problem is a COPD with a chronic CO2 retention, and the bicarbonate has increased to compensate for it. But now you are finding that the patient has actually become more alkalotic and the bicarbonate has remained high. The PCO2 is also high, but that is not contributing to acidosis. Now the golden rule of ABG is that a compensation cannot overcompensate. Okay? So if this bicarbonates are increased because it has to compensate for a primary respiratory problem like a chronic respiratory acidosis, then this pH cannot become more than 7.4 because it cannot overcompensate. So something else is going wrong. So what is happening here? So this is what I was talking about, post-hypocapnic metabolic alkalosis. That means this patient probably lives at a PCO2 which is much higher, maybe at around 60. Okay? Suddenly something has happened which has made this patient more tachypnic and causing another respiratory alkalosis which is happening on top of a chronic respiratory acidosis. And the commonest cause that happens without suddenly causing respiratory alkalosis, or at least you have to rule out that cause, is, what is this? Pulmonary embolism. So pulmonary embolism in a patient with chronic respiratory acidosis will trigger a post-hypocapnic metabolic alkalosis. Okay? So for this patient, 48 is hypocapnia because probably he lives around 60. But because of tachypnea, the carbon dioxide has come down, but the bicarb takes much longer to come down because the kidneys take a longer time to readjust the bicarbonate levels. So this is post-hypocapnic metabolic alkalosis. Okay. Next one. Unconscious patient with a low blood pressure after some query toxin ingestion. We don't know what is it. Again, quickly going through it. pH 7.21, acidemia. PCO2 70, so that is contributing to it, so respiratory acidosis. What should be the compensation? Compensation will be done by the bicarbonate. So 1 milliequivalent of bicarbonate will increase for every 10 rise in carbon dioxide because this is an acute condition. The patient is acutely unconscious. So 70 minus 40, that is 30 by 10 or 3. So appropriate compensation is 27. What is the bicarb here? 27. So appropriately compensated. Great. What is the anion gap? 140 minus chloride 89 plus 27. So 24. So 24 of anion gap, is it high or is it normal? It is high. So that means there is some other problem which is going on. So that brings us to something called the delta ratio. What is delta ratio? Delta ratio is a delta anion gap by the delta bicarbonate. So the delta anion gap, the average anion gap is taken as 12. Okay? So in this patient, what is the change in anion gap? 24 minus 12, that is 12. What is the change in bicarbonate? The patient's bicarbonate 27 minus mean, 24 is taken as the mean, that is equal to 3. So 12 by 3, 4 is the delta ratio. Now, if the delta ratio is more than 1.5 or sometimes 2, it implies that there is another metabolic alkalosis plus a metabolic acidosis. Okay? There can be anything causing CO2 retention. For example, the commonest being alcohol ingestion. So in this patient, you can also check an osmolar gap, which is measured via calculated osmolarity. And the calculated osmolarity, you know, 2 into sodium plus BUN plus divided by 2.8 plus glucose by 18. And if you find an osmolar gap, there can be another unidentified substance causing metabolic acidosis like ethanol or antifreeze, etc. Okay? So this is the delta ratio. You should remember anion gap, delta anion gap by delta bicarbonate. In this patient, there was no osmolar gap. That means there was no, so what is the invisible molecule that is causing metabolic acidosis here? So in this patient, there is respiratory acidosis, metabolic acidosis, high anion gap, and metabolic alkalosis. So the invisible molecule is lactate, which is not mentioned in your ABG. The lactate was here 5.5. What was the cause of metabolic alkalosis? Obviously the vomiting or maybe a nasogastric wash which you received in the emergency. So the final diagnosis for this patient is a metabolic alkalosis because of GI loss, metabolic acidosis because of high lactate, probably he is dehydrated, and this can balance each other not to reveal in the ABG. So the ABG did not reveal any metabolic problem. So if you just end here by saying bicarb of 27, which is compensated, appropriately compensated, your diagnosis just becomes respiratory acidosis, okay? So that's why we go one step forward, we check what is the anion gap, we find the anion gap is high. So anion gap is high, but ABG does not reveal any metabolic acidosis or alkalosis. So that means there is both metabolic acidosis and alkalosis, and that's how you prove it with the delta ratio, metabolic alkalosis plus metabolic acidosis. Cause of metabolic acidosis can be something that can be measured or something that cannot be measured. Something that can be measured, commonest is lactate. Something that cannot be measured are usually your ethanol, methanol, glycols, ethylene glycol and all. Antifreeze are not available in our country, so we don't need to much bother about it. But obviously ethanol and methanol is available, and you can also get another molecule called a propylene glycol. Propylene glycol is sometimes used as a vehicle for various drugs, right? Even antibiotics, antifungals like voriconazole as an antifungal uses propylene glycol as a transporter. So if a patient renal failure is getting these molecules, they are going to accumulate and is going to cause metabolic acidosis. Does anion gap tell you about lactate or not? So the answer is anion gap does not accurately identify lactate. So lactate must be directly measured. You cannot find it out either from anion gap or from base excess. Okay, so that is a problem. Okay. A lady came to the ER with shock after vomiting, diarrhea, and this is the ABG that we find. pH of 7.41, PCO2 42, bicarb 26, sodium 146, potassium 3.2 and chloride 92. What is your assessment about this ABG? Is there any metabolic abnormality in this ABG? The pH is normal or not? pH is normal. PCO2 is normal or not? Normal. Bicarbonate normal? Yes, normal. So no problem. High anion gap. So there is no metabolic abnormality. Just by looking at the ABG, no metabolic abnormality. But is it possible? The patient is in shock, is in the ER. pH normal, PCO2 normal. But look at the anion gap. The anion gap is 28. What is the delta anion gap again? 28 minus 12, so 16. What is the delta bicarbonate? Minus 2. Minus 2. Okay? So if the pH is low, it means metabolic plus chronic respiratory acidosis. So here your pH is normal. So that means this is not metabolic plus chronic respiratory acidosis. If the pH is normal, it is high NN-gap metabolic acidosis plus metabolic alkalosis. So that is what is happening here. This is high NN-gap metabolic acidosis plus metabolic alkalosis. Why is metabolic acidosis? Because of shock, because of lactate. Why is metabolic alkalosis? Because of GI loss, right? So golden rules, compensation, mostly these golden rules are true, okay? ABG is something which always violates itself because it is very, very difficult to predict your body. But still, body usually never overcompensates. So if you say that your compensatory mechanism has overcompensated the pH, that is not possible. There must be a third problem happening, existing. Compensation does not bring back pH to normal. Absolutely, to bang normal, it is very difficult. Okay? So always search for another problem or another mechanism. Maximum time required for respiratory compensation is approximately 24 hours. Minimum time required for metabolic compensation is 12 hours. What does it mean? Respiratory compensation happens fast. It starts happening within hours, and within a day it will be compensated. Kidneys take at least 12 hours to start compensating, and it will happen over a few days. Okay? Now in metabolic disease, if appropriately compensated, this is a shortcut I was talking about, the CO2 in millimeter of mercury is equal to the first 2 digits of pH after the decimal point. So for example, here the pH is 7.27, bicarb of 25, and 11 is your PCO2. So 27 is approximately, 7.27 is the pH, 25 is the PCO2, and 11 is the bicarb. Okay, so this is a metabolic acidosis. So 27 is approximately equal to 25, which is the measured PCO2. Approximately equal. Okay, you can do it for metabolic alkalosis as well. So this is the kind of a normogram or a plotting of the bicarbonate, predicted PCO2 from the bicarbonate. And this red line is what you get from the Winter's formula.
Chandrashis, you have 5 more minutes to wind up before we open for discussion.
Okay. So from the Winter's formula, whatever you can get is approximately here. You will find only in the extremes they deviate from the shortcut. So for most of it, the shortcut is usually valid, and the same is true for alkalosis as well. These are the compensatory formulas. This is the Winter's formula, which is usually most useful. What is the predicted carbon dioxide from the bicarbonate? For metabolic alkalosis, it is 0.7 into the delta bicarb. And respiratory acidosis and alkalosis we will not discuss much because we are not discussing much about respiratory. Okay, now let me move to, because we don't have much time, so let me move to something that is more important, that is metabolic acidosis. So metabolic acidosis, again, if you have a bicarb less than 20 and a pH of less than 7.38, you can suspect metabolic acidosis. You look for an anion gap and a corrected anion gap. Corrected anion gap is basically corrected for albumin. So 0.25 into 40 minus albumin. Increased anion gap or normal anion gap. If you have increased anion gap, the cause are usually ketone bodies or ketoacidosis, whatever may be the cause, diabetic, alcoholic, starvation. You can have lactic acidosis, either L or D lactate. Renal insufficiency, only if it is chronic and very severe. And certain other group of toxicities like acetyl salicylic acid, paracetamol, acetaminophen, etc. So The next thing that you do is basically calculate what is the osmolar gap. If you find a gap, that means there is a hidden molecule. So these can be the hidden molecules which are there, the methanols and the ethylene glycols. And if there is no osmolar gap, it is pyroglutamic acid basically happens from acetaminophen toxicity, so there will be a history of increased acetaminophen intake. The other side is your normal anion gap, and you look at the urinary gap, whether it is negative or positive. If it is negative, then you have GI losses, proximal tubular acidosis, acetazolamide, etc. And the positive ones are all this. So this we have discussed. Lactic acidosis is a different beast. It will take a completely different class to discuss what is lactic acidosis, what is the significance, what it means, and whether it is at all an acidosis or not. But what I wanted to say is that there are so many molecules which can contribute to lactic acidosis, and it needs sometimes you have to be very cautious not to keep on over treating high lactate, especially in a acute setting. So this is a very good cartoon which talks about an approach to normal gap metabolic acidosis. The first step is to ask the question if the patient has received a lot of saline infusion. Okay? So usually, unless you have given almost like 50% or more than 50% of plasma volume of saline, so for a normal person, let's say the plasma volume is 3.5 liters. So unless you have given more than 2 liters of saline, it should not cause much of a acid-base problem if the kidneys are normal. So if the patient is receiving saline infusion, either stop or switch to LR. Did the acidosis resolve? Yes. So that means it was caused by a hypertonic saline. If no, look at the creatinine clearance. If it is less than 40, or I will say probably less than 30, then normal and ungap metabolic acidosis can happen because of renal failure itself. In fact, 50% of the acidosis for renal failure is normal and ungap, and only in very severe renal disease you get a high ungap, and that actually happens when your sulfates and phosphates and other non-excreted stuff in blood increases. Then assess for serum potassium, urine pH, and urine anion gap. The urine, if the potassium is normal or low, the urine pH is low, and the urine anion gap is also low or negative, then you have to talk about the GI causes. Okay? If it is urine pH is high and your urine anion gap is high, then you can have a type 1 RTA. Urine pH variable but urine anion gap low or negative, type 2 RTA. Potassium high, urine pH low, urine anion gap high, type 4 RTA. And very high potassium, that means above 7 usually, itself can cause metabolic acidosis from hyperkalemia. I don't have much time to explain the causes or the pathophysiology of different renal tubular acidosis, but you can probably just see that it is type 2 is basically a proximal RTA where there is more of a bicarbonate loss, and type 1 is where there is more of a acid secretion in the urine, and type 4 is hypoaldosteronic state where there is again a potassium hypokalemia and alkalosis. So these are the causes of type 1 RTA, and usually in adults they can present with hypercalciuria and nephrolithiasis. These are the causes of proximal RTA. In adults can present with osteomalacia, in children can present with rickets. Fanconi syndrome is a particular variety where you will have also a loss of glucose, phosphate, amino acids, etc. And this is RTA4 with decreased renin, decreased angiotensin 2 or decreased aldosterone. And there are certain drugs which should be avoided in these patients like NSAIDs and aldosterone antagonists, heparin, cyclosporin, which can all worsen it. This is a cartoon which will take a little bit long time, but this is something which is necessary for us to understand, not only for renal tubular acidosis, but also to understand metabolic alkalosis. So if you have a low renal perfusion, which starts from here, there is renin secretion which causes angiotensin to angiotensin 2 conversion, and which further stimulates aldosterone release. And aldosterone as well as angiotensin 2 both will in the kidney will cause sodium reabsorption, bicarb reabsorption, potassium secretion and H+ secretion, leading to metabolic alkalosis. There's various drugs which can inhibit at various levels. So this is the cause of metabolic alkalosis. And the type 4 RTA will basically present with metabolic alkalosis. Not only that, there will be aciduria, there will be hyperkalemia, and this is the comparative chart of it which you can go through. What is urine anion gap? Urine anion gap is basically the urine sodium plus potassium minus chloride. It's usually normal for you to have a positive urine anion gap, that is +20 to +90. But when it becomes negative or very low, that is -50 to +20, that means the unmeasured cations, which is basically ammonium, is increasing. Okay? So, which again basically means that your kidneys are functioning right. And this is the mechanism because of which only hyperkalemia can cause metabolic acidosis. So only hyperkalemia will inhibit the potassium H+ exchange here, and therefore it will cause therefore it will cause the acid levels or H+ levels in blood to rise, and it will stop the H+ release into the ureters. So with that, I think I'll end. Only thing is that urine osmolar gap is something which I'll take just 1 second. If there is large amount of other ions in urine, like hypurate in toluene poisoning basically happens from glue sniffing, or acetoacetate or hydroxybutyrate in blood, the urine anion gap is not very useful. So in that case, you have to do a urine osmolar gap, and if the osmolar gap is less than 150, that implies there is impaired ammonium excretion. The next set is completely about Stewart's approach, but I don't think I have time to discuss all that. So I will stop here, and if again we have time, we will discuss Stewart's approach in some other class. Thank you very much. If you have any questions, you can ask.
A big round of applause for Chandrashishda for making this extremely difficult topic simple for us. If there are any questions from the residents or from any other attendees, you can please ask the question. Please come to the standing mics in front of you and you can ask questions regarding any aspect of blood gas analysis that you might have faced in your clinical practice, any interpretation difficulties. I think Parthoda has a question.
Chandrasis, yeah, nice talk. 2 questions. Number 1, with the availability of newer machines, do we still consider the normal anion gap to be 12 ± 4, or it's lower?
Sorry, normal?
What's the normal anion gap with the availability of newer machines? Is it still 12 ± 4? It is somewhat lower than that.
Normal anion gap, yeah, for all calculations we'll take it as 12. We will take the delta from 12. And obviously the anion gap has to be corrected for albumin.
And second one is somewhat easier to diagnose high anion gap metabolic acidosis with metabolic alkalosis. But as a group, we deal more with normal anion gap metabolic acidosis in the form of RTA. Some of them may have underlying metabolic alkalosis as well. So how do we suspect or diagnose normal anion gap metabolic acidosis and metabolic alkalosis?
Yes. So Normal anion metabolic acidosis, so first of all, we will have what? I mean, the anion gap will be normal, obviously. And if we have a metabolic alkalosis, then the delta bicarbonate will be negative because it will be above 24. So if you have a delta bicarbonate which is above, which is negative, let me just go back to this.
Slides, could you please load the slides again?
Oh, okay, no problem. So we said that we have to do a delta bicarbonate, okay. So delta anion gap plus bicarbonate should be 24 plus minus 6. So here your delta anion gap will be normal. But your bicarbonate, your plus bicarbonate, this will be basically high. So your bicarbonate will definitely be say 28 or 29, whatever it may be. It cannot be less than 24. So this will become 24, this number will become more than 24 plus 6.
So can we rely on, say for example, standardized base excess to diagnose normal anion gap metabolic acidosis?
Base excess?
Yep.
So standardized base excess assumes that your carbon dioxide is normal, which you may not have in a patient who is coming to you with a chronic metabolic alkalosis. So we don't usually now rely on standard base excess anymore. So in this case it will be easier because if there is normal anion gap metabolic acidosis, your delta anion gap will be normal, but when you add this together, delta anion gap plus bicarbonate, it will be more than 30. Okay. If it is more than 30, that is 24 plus 6, but your delta anion gap is normal, so there is normal anion gap plus metabolic alkalosis.
Thank you.
Very basic question, that's how often would you need to calibrate your instrument, and what are the parameters which we can straightaway rely upon, sodium, potassium, whatever we get, can we rely upon from the blood gas analysis machine?
There are two things which are only measured. One is the pH and the other is the PCO2. So I'm not talking about the oxidation parameters here. So bicarbonate is always calculated. So there are two electrodes basically. We have a separate biomedical team who does it. So I think they do it every week or twice a week, something like that. But these are the two things which, so bicarbonate is always calculated. So the only two things which needs to be calibrated is the pH and the PCO2.
A nice talk.
Thank you.
Often we do see there is a disparity in the sodium concentration in ABG machine, potassium and calcium also. So what's your opinion regarding this? So sometimes we do see, particularly in the neonatal ICU, the calcium level is very low. But we do not know when we checked again in the serum, it is so-so. It may be in the lower range, but it is not to that extent. So sometimes we are a little bit confused regarding that. So do we start treatment or not?
These are all calibration problems of the machine. If there is any doubt between these two, I think you should rely on the lab parameters rather than the machine. The only exception is bicarbonate. The bicarbonate which is measured in the ABG machine may not be the same as measured from the lab.
Yes.
In that case, we take the bicarbonate which is there in the machine. Because bicarbonate is a molecule which can change by the time it goes to the lab. Because of hydrolysis from the carbonic acid, the CO2 which is dissolved in the blood can continuously release bicarbonate. So a high CO2 can also increase your bicarbonate in a stagnant blood. So in that case, we'll rely on the ABG, which is either done immediately or you have put it in ice, and you can, I think, do it up to 2 hours if you don't have a ABG machine very nearby.
Yeah, this is a nice.
That is the only exception. Other than that, if you are measuring calcium or sodium or potassium, I think standardized lab parameters will be better if you have a discrepancy. For us, we don't find a lot of discrepancy. The only thing that we look from the ABG is an ionized calcium value,
yes,
which is something that we look from the ABG, and most of the time that is the first thing which helps us to suspect a hypercalcemia in our patient. We don't get too many hypocalcemias, but hypercalcemia we get especially patients who come with altered sensorium.
Okay.
And from that we start our diagnostic algorithm why this patient is hypercalcemia, etc. Any other questions? Yes.
In few of the ABGs we get bicarbonate, one is actual.
Sorry?
Sir, in few ABG reports we often find there are two bicarbonate values, one is actual and another is standard. So which one to take? For
Standard.
And what is the interpretation of the actual bicarbonate level?
That I just told you. So actual bicarbonate is variable because it is also dependent upon your something called the total CO2. So total CO2 is basically your PCO2 plus the CO2 that exists in blood in association with H plus as a carbonic acid, and it hydrolyzes to form bicarbonate. So that is the actual which is being calculated. But standard bicarbonate is the one that you should usually use for the calculations which we are doing.
Okay. Thank you.
I think we had a wonderful discussion for our opening workshop. Big round of applause for Chandrashishda and for all the guests. I'd like to request Professor Chaudhary sir to please felicitate our first speaker for our workshop with a token of appreciation. We have two quick housekeeping announcements. All delegates who have been pre-registered for this workshop are requested to collect, and spot registered as well, to collect their registration certificates from the registration desk outside at the end of the session before you leave. And last but not the least, we have dinner arranged downstairs on the ground floor after the program and the inauguration program after 7 p.m. For all delegates, please do not forget to enjoy the gastronomic dinner downstairs. We now quickly move on to the second workshop topic, which is equally interesting for endocrinologists and physicians alike. We have this workshop on sleep study or polysomnography. Can I have the CV slide? To be delivered by Dr. Sabyasachi Chaudhary, who happens to come from Medical College, Kolkata, from the Department of Respiratory Medicine, and he will take us through how to interpret and how to treat our patients based on a polysomnography report. Dr. Chaudhary, please.
First of all, I want to give the thank you for the organizers to give me a chance to present something about the polysomnography, which is a emerging topic. So I am starting. I am Dr. Sabyasachi Chaudhary, Associate Professor from Department of Respiratory Medicine, Medical College, Kolkata. First I will show you some sleep study cases, and then I will tell elaborately about the polysomnography and how to interpret this polysomnography. Now this is the first case. This is a 50 years old male, 55 years, who come to a chamber with complaints of shortness of breath. He has gained 10 kg weights over the first 6 months and feels that his breathing is more difficult when walking up a flight of stairs. And there has been no cough or sputum production, and he has no other respiratory complaints. And
He has a childhood history of asthma and has not been any exacerbation in the adult. His past medical history also relevant for the hypertension, recently diagnosed non-insulin dependent diabetes and hyperlipidemia. He is an ex-smoker, and his wife, who accompanies him on his visit, mentions that he has been more tired lately when he comes home from work and travel concentrating on task. She often finds that he has dozed off in front of the TV while waiting for the dinner. He has restless sleeping during the night, and she is getting tired of having own sleep disrupted with his loud snores. He does a little else but sleep during the weekends, and she worries that he might have a sign of depression. These are the cases. And on further questioning, he admits that he has been more sleepy at late, and he occasions falling asleep during the meetings, and much of his embarrassment colleagues nudge him awake when his snoring starts. He goes to bed around 11 p.m., falls asleep quickly, but may wake up several times throughout the night to go to the bathroom. He wakes up about 7 a.m. to get ready for the work and has to drag himself out of the bed. His Epworth sleepiness score is 12 out of 24. I will tell in details about the Epworth sleepiness score. He doesn't take any scheduled naps during the week, but tries to catch up during the weekends by sleeping in and taking the afternoon naps. He has not been seen in any car accident due to the sleepiness. His physical examination is remarkable, with blood pressure is slightly high, oxygen saturation is 95% on room air, body mass index BMI is high, that is 35, and Malambatic score 3. Highest palate, he has highest palate, neck size is 17.5 inches, respiratory, cardiac and abdominal examinations are otherwise unremarkable. So what are the important components of it? From these we can get some questions, that is what are the important components of a good sleep history, and what is the differential diagnosis of the daytime hypersomnolence? They are not and what are the available tools to measure the daytime hypersomnolence? So, and what are the important components of a good sleep physical examination? What are the risk factors for the obstructive sleep apnea, and what are the symptoms of the OSA? So, coming on the first important component of the good sleep history, we should talk about what is the duration of the sleep history. If the patient's duration of the sleep and the sleep latency, total sleep time, this has, and the wakeful time, this has to be noted when we will taking the sleep history. And there are the differential diagnosis of the daytime hypersomnolence, and the most common is the obstructive sleep apnea syndrome. This is the most common, and we are encountering it very much. Others different neurological problems like narcolepsy is there, then idiopathic hypersomnolence is there, some due to the some toxins, drugs, head injury, maybe the hypothyroidism or the endocrine disorders. These are the differential diagnosis. And the what are the available tools? One is the different scales are there, like Epworth sleepiness scale, multiple sleep latency test, we can do that, but the important thing is the polysomnography. It is the gold standard, and by polysomnography we can only measure whether the patient has this obstructive sleep apnea or the other things. And what are the symptoms of the OSA? This patient probably has OSA. And what are the symptoms? These are the symptoms, that is the patient has loud snoring, excessive daytime sleepiness, then patient may be nocturnal awakening, frequent nocturnal awakening, nocturia may be present, and patient has decreased concentration during the work at daytime, patient easily dozes while the sitting idly, maybe some car accidents or occurs. So, the diagnostic testing is that polysomnography. Here it is here you can see that ঠিক আছে স্যার। পয়েন্টারটা একটু পয়েন্টার Okay. So here there are you see that there is airflow is absent in these cases. Airflow is absent, but the abdominal and the chest movements are there. Though these movements, abdominal and the chest movements are not as these areas when there is normal sleep, but here there is apnea. This is the tracings we will get in the obstructive sleep apnea, where there is airflow is absent, but the movement of the abdominal movements and the chest movements are there. So now I will go in details about the polysomnography. I am ending this. So yes. So I am telling in details about the polysomnography, then I will go into the cases again. So this is the, I will tell what is the polysomnography, what are their interpretation, and otherwise because it is the gold standard I am talking about the polysomnography, so I will rely mainly on the polysomnography. So these terms was proposed by the Holland, Demet and the Renal, and the most commonly, it is the most commonly used test and it is the gold standard for the diagnosis of the obstructive sleep apnea, and it consists of the simultaneous recording of the multiple physiological parameters related to the sleep and the wakefulness. So these are the indications, the sleep related breathing disorders during the CPAP titration in OSA for the assessment of the treatment, and for sleep related behavioral disorders also can be diagnosed. Atypical or unusual parasomnias, narcolepsy, neuromuscular disorders and the sleep related symptoms, paroxysmal erosion or seizure phenomenon, periodic leg movement disorders and parasomnias which not responding to the conventional therapy, all are the indications for the PSG. So initial assessment, detailed medical and the psychiatric history should be taken, medication, smoking, alcohol, activities on that day. Then the assessment of the sleep, I have already told the sleep history for the last 24 hours, what we have taken, that is the duration of the sleep, sleep latency, total duration, then the sleep efficiency, we should take this, and the sleep scoring systems. What are the sleep scoring system? There are different sleep scoring systems are there, but the Epworth sleepiness scale is usually used. This is the Epworth sleepiness scale, where this is categorized as a this is no chance of dosing, slight chance of dosing is 1, moderate chance of dosing is 2 and the high chance of dosing is 3. So the highest score is 24, and if the score is more than 10, there is every chance of patient has having any sleeping disorders. Now these are the questions which are asked, that is whether the patient is dozing during the sitting and reading, during the watching TV, sitting inactive in a public place like in a cinema hall or theatre, as a passenger in the car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after a lunch without the alcohol intake, and in a car while stopped for a few hours in a traffic. These are the questions asked, and according to that the scoring is done, and if the scoring is more than 10, there is a chance of the sleeping disorders are more. So this is the recording room. We should know about the in-lab polysomnography. The study patients and the monitoring apparatus and the technologies are housed in the adjacent rooms. Recording room should be as homely as comfortable. It should be soundproofed and air conditioned, and intercom system to interact with the patient should be there. And this toilet, restroom, these should be present, and rheostatically controlled lighting should be there. This is the recording room with the study subject, and this is the recording video cameras. These photographs are taken in Kolkata in a sleep lab. It is not from outside. This is the monitoring room for the technicians. What are the instructions to be given to the patients? Reporting time. 1 hour prior to the usual time of the sleep. A prior visit to familiarize with the lab is useful. Patients should have a relaxed day without daytime sleep. A head wash, because the EEG lead should be given. Adequate food should be taken. Abstain from the caffeine in the afternoon and evening of the day on which the PHG is planned, and avoid alcohol on that day. Avoid strenuous exercise. This has to be done by the patient. And patients' other instructions are to continue their usual medications on the night of the PSG, including the sleep aids. The medications should be recorded by the technician so that the results can be optimally interpreted. Avoid stimulants, including medications for narcolepsy, and avoid naps on the day of the sleep study. So what are the components? First component are the EEG. It distinguishes between the wakefulness and the various stages of the sleep. A minimal of the 3 channels representing the right frontal, central and the occipital electrodes referenced to the contralateral mastoid electrode is recommended. So these are the electrodes. This is the EEG electrode, that is the occipital electrodes. This is the EEG electrode, that is central electrode, and this is the EOG, that is the electrooculogram electrode. 10 to 20 electrodes may be placed, but the thing is that minimum 3 channels should be placed at right frontal, central and the occipital. Now the EEG signals during the different sleep stages. This is the NREM sleep and this is the REM sleep. Here you can see that these are the alpha waves during the wakefulness. During the light stage of the sleep, these are the theta waves are present. In N2 sleep, these are the sleep spindles and the K complexes are present. This is the deep stage of sleep where the delta waves are present, and this is the REM sleep. So these are the physiological. Then the electrooculogram, 2 recommended electrodes are labeled E1 and the E2. E1 is placed 1 cm below the left outer canthus, and E2 is placed 1 cm above the right outer canthus, both reference to the right mastoid. And this allows the simultaneous recording of the both vertical eye movements such as blinking and the horizontal eye movements, both slow and the rapid. It documents the onset of the rapid eye movement sleep and note the presence of the slow rolling eye movements that usually accompany the onset of the sleep. So these are to be placed here. I have already shown you. These are the electrooculogram electrode. Now the electromyography, EMG, helps to determine the sleep stage and helps to classify the variety of parasomnias like the restless leg syndrome. We can diagnose from this. We can diagnose these periodic limb movement disorders can be diagnosed by this EMG. The minimal components are the chin EMG channels, record activity from the mentalis and the submental muscles, the mylohyoid and the anterior belly of the digastric, and the bilateral leg EMG channels record activity from the tibialis anterior muscles. And the tonic EMG level in axial muscles usually decreases from wakefulness through stage 1 to 3 of the NREM sleep and normally absent in the REM sleep. In the limb EMG, these are the electrodes placement, and this is the signals when the patient is asked to move his feet. These are the signals. Now the respiratory monitoring, it is most important. Upper airway airflow, thoraco-abdominal movement should be seen, snoring monitors and the indirect arterial blood gas monitoring. Upper airway airflow, the oronasal thermistor device, thermistor or the thermocouple should be placed between the nose and the mouth, is commonly used to monitor the airflow by detecting the changes in the temperature, because airflow is very much important to monitor. And thermistor consists of the wires records the changes in the electrical resistance, and the thermocouples consisting of the dissimilar metals register changes in voltage that results from the temperature variation. So these nasal prongs connect to the pressure transducer, detect the inspiratory flow, and may be the most accurate method to identify the certain inspiratory flow limitation, that is the hypoapnea. And nasal pressure transducer are necessary for the diagnosis of the hypoapnea, and the thermistors we have already told are necessary for the diagnosis of the apnea. This is the thermistor, and then about the thoracoabdominal movement. This measures the changes in the thoracoabdominal cross-sectional areas, and the sum of these two compartments is proportional to the airflow, and sensors the two air coils, one placed around the chest and another around the abdomen. These are this is the chest band and this is the abdominal band. These are the sensors for the respiratory effort. This is the transducers for thoracoabdominal movement. This can detect the transducer. Then I am going into the this respiratory effort signals. This is the respiratory effort signals. This is detected by the during the normal sleep. Now the snoring monitor, although snoring monitor can be monitored by placing a miniature microphone on the patient's neck, there is no accepted grading system to quantify the intensity of this parameter. In practice, the technology's notation as the study is being recorded as well as the polysomnographer's review of the audio as the study is being read provide a better estimation of the degree of the snoring. This is the snoring monitor. This may be placed, and this is the snoring channel placement here. By this way we can detect the snoring also. ABG is not usually done, but the measurement of the PCO2 in the morning after the sleep study can be compared to the awakening PaCO2. So ABG, if it is possible, it can be done, otherwise it is usually not done due to the cost. But the oxygen saturation has to be monitored, and the continuous oxygen saturation monitoring by the finger pulse oximetry is routine, and PhD reports mention the time of the patient spent with an SpO2 below 90. This is the oxygen sensor. So, and the ECG should be placed. ECG, why the ECG is important? Because it will detect the sinus arrhythmia, extrasystole, prolonged asystole episodes, atrial or ventricular fibrillation, nocturnal angina. This can be detected by the ECG. And the body position may be the supine, left lateral, right lateral, and the body position is monitored throughout the test using a position sensor and or video monitor. So what are the derived information? Total sleep time. The total sleep time is the total duration of the light sleep, deep sleep, and the rapid eye movement sleep. It should be 7 to 8 hours. At least minimum 6 hours. If it is below, then normally then there may be the sleep deprivation or other causes may be there. Sleep efficiency is the total sleep time divided by the total recording time. Sleep stage percentage, what is the percentage of the REM and the NREM sleep? And the sleep stage latency, that is the latency to any sleep stage, is the duration from the sleep onset to the initiation of that sleep stage. This is called the sleep latency. It is also important, especially during the detection of the narcolepsy. Arousal ranges from the full wakefulness to the 3 seconds transient EEG shift to the lighter stage of the sleep. And arousals are generally counted and then divided by the total sleep time to give the number of arousals per hour of the sleep, that is the arousal index. The most important things are what are the apnea and what are the hypoapnea. Apnea is the cessation of the airflow for at least 10 seconds, and the hypoapnea is the decrease in the airflow of more than 30 seconds lasting for more than 10 seconds associated with either more than 3% desaturation from the pre-event baseline or arousal. And the respiratory RERA, that is an event characterized by the increasing respiratory effort for 10 seconds or longer, leading to an arousal from the sleep, but one that does not fulfill the criteria of the hypoapnea or apnea. So apnea hypoapnea index is important. That is the average number of the episodes of the apnea and the hypoapnea per hour. And the respiratory disturbance index, that includes the apnea, hypoapnea and RERA per hour. And any AHI and our respiratory disturbance index lower than 5 per hour is considered to be within normal limit. So during the obstructive sleep apnea, there is the apneic episodes, but the abdominal and the chest movements are there. And there may be some hypoapneic episodes are there, but the abdominal chest movements are present. This is the hypoapnea. This abdominal and the chest movements are there, but the flow is decreased. Where the central apnea, in central apnea there is no airflow, no respiratory effort for that lasting for more than 10 seconds. And mixed apnea, where there is respiratory episode, that are features of the both obstructive and the sleep apnea in the same event. So ASM criteria for the diagnosis of the OSA is mild if the apneic and the hypoapneic episodes are 5 to 15, if it is moderate 15 to 30, and it is severe more than 30. By the polysomnography we can divide it this by mild, moderate and severe. So I will tell something about the PSG types. Level 1 device, I have told about the level 1 device. Level 2-3 devices refers to the home studies recorded by the portable device with progressively fewer channels measuring the progressively fewer parameters. So level 2 mainly the 7 channels, this EEG, EOG, CHIN, EMG, ECG, oximetry, airflow and the respiratory effort channels. Level 3 is then lower 4 channels including the airflow, heart rate or ECG and the oxygen saturation. The level 4 device, this type of device does not meet the requirements, only measures the 1 to 2 parameters, that is oxygen saturation or airflow. So level 1 or level 2 devices we should use for the detection of the sleep related disorders. The split night study, what is split night study? Diagnosis of the OSA is established during the first portion of the study, and amount of the positive airway pressure that is necessary to prevent the upper airway collapse during the sleep is determined by using the CPAP machine during the remaining portion. So first half of the study we will do the sleep study, and in the second half of the study we will do the sleep CPAP titration. This is called the split night study. These are the limitations of the PSG. The first night effect, that is the reduced sleep efficiency, increased awakening and arousal due to the use of these channels, prolonged sleep and the REM latency, decreased percentage of the REM and the slow wave sleep, increased percentage of the light sleep. These are the limitations. Technology, and it is technique dependent, so there may be the technology's faults is there. The episodic disorders may be missed like seizure, parasomnia, night to night variability is there. So I am again going to the first case, that is the obstructive sleep apnea case. So this is the tracing. Again you can see here so you can see here there is absence of the airflow, but thoracic and abdominal movements are there. By this way we can diagnose it clearly. This is the this obstructive sleep apnea. Then oxygen desaturation from these areas we can detect. There is oxygen desaturation is there. We can detect from the polysomnography. So we can make the treatment recommendations also, and so what are the treatments available for the OSA and what should be recommended for this patient? And if the OSA is associated with the long-term health outcomes, and what are the proposed mechanisms for the association of the OSA and the cardiovascular outcomes. So regarding that treatment outcome, we should use the CPAP machine for this. Though there are the other treatment outcomes are there, like the different surgical outcomes are there, like palatopharyngoplasty, these, but initially we should use the CPAP. If the patient cannot tolerate the CPAP or there is a difficulty to use the CPAP at night, so we can in that case we can going to the surgical treatments. Otherwise we should stick to the CPAP. And there are the long-term health outcomes are there, different health outcomes. There is a high chance of hypertension, there is heart rate is increased, there is usually the heart rate is increased, then MI chance is more, and the respiratory problems are more in obstructive sleep apnea. This hypoventilation, prolonged hypoventilation can occur, and if the patient has COPD, then this can be worsened. So in this case we prescribe the CPAP at about 12 centimeter water and use the medium sized or full face mask. The face masks are different types. One is nasal face mask, one is the full face mask, and usually we will use the full face mask, but the nasal face mask can be used. So in this case, this patient returns after the 3 months of the CPAP use and reports the improvement of the daytime hypersomnolence, and he has been paying attention to his diet and has been exercising more than 10 kgs weight loss, and he reports nightly use of at least 5 hours with initial difficulty tolerating the mask but the gradual increase in tolerance, and he uses the humidifier that has helped somewhat. So what are the follow-up recommendations? The follow-up recommendations that stick to the CPAP. There may be some difficulties initially, but ultimately the patient will tolerate the CPAP. And impact of the weight loss is very much important. Patient has to reduce the weight because weight has a negative impact on the obstructive sleep apnea. So patient should reduce the weight. Then this is the another case. Patient is a female patient, COPD on triple therapy, high BMI index again. He has IST, hypertension, echo is normal, LV function. They have fibromyalgia on NSID, breathless. He is housebound, non-smoker, and no past history of the acute hypercapnic or NIV use. Sleep study shows the nighttime arousal, snoring, and the excessive daytime sleepiness. No witnessed apnea. Oxygen saturation on room air is 94%. Bicarbonate 26. pH 7.4, PCO2 37, PO2 67, and almost these are the normal. This is the X-ray, this is the CT, and this is the PFT. PFT shows the obstructive airway disease. This coughing pattern is there. So home overnight oximetry so can detect the saturation and the pulse, and this is but this is unreliable in COPD and other respiratory disease. And here also the polysomnography is the gold standard. So in polysomnography, AHI more than 5 per hour, oxygen desaturation index more than 5 per hour, drop in oxygen saturation of 3% to 4% or more, hypoapnea may be present, and at least 4 hours of recording. This should be there. In this patient, the AHI is 21.4 per hour, oxygen desaturation index is 23, and there are this high degree of the snoring. So again, there is desaturation occurs. This is the areas of the hypoapnea on PSG, and this is the area of the apnea in PSG. This is the area of the hypoapnea, this is the area of the apnea in PSG, and oxygen desaturation occurs here. Here also same thing. So this is called the overlap syndrome, COPD and the OSA. 10 to 30% of the COPD patients are undiagnosed. FEV1 is less than 65%. They may be the current smoker, ex-smoker. Daytime hypercapnia is usually present, and worse prognosis than either alone, and more severe nocturnal hypoxemia, pulmonary arterial hypertension, arrhythmia are more common in these patients. This may be due to the VQ mismatch, due to the sleep hypoventilation. Compensatory mechanism stops during the sleep, and the sleep blunts the ventilatory response and the drive. And the dilator muscles loses tone during the sleep, inspiratory flow reduced, expiration time decreased, and increased lung volume in emphysema. When to worry? Patient has excessive daytime sleepiness, snoring, high this Epworth scale, obesity, usual nape circumference is usually high, more than 17.5 inches, opioid use may be present, heart failure, polycythemia, borderline daytime SpO2 is less, pulmonary hypertension may be present, overnight oximetry not sufficient. Treatment is the weight reduction, medicines for COPD, smoking cessation. CPAP improves the mortality, but clear benefit is unlikely. NIV in these cases may play a role. If the patient requires the CPAP of more than 15 centimeter of water, then we can switch from the CPAP to the NIV. But the oxygen never should be given, because if the oxygen will be given, then the respiratory drive will be abolished. So CPAP or the NIV can be given. So these are the COPD and the sleep-related bleeding disorders, OSA or overlap syndrome, nocturnal hypoxemia, sleep-related hypoventilation, and the central sleep apnea. One can be present with the COPD. The third patient, 59-year-old, this excessive daytime sleepiness or the Epworth sleepiness score is more than 20 with snoring and the apneic episode, COPD, smoker, BMI is also somewhat high. Here the HI is somewhat low, 5.9 only, and the snoring is also less. Here desaturation occurs, but the other things, that is the apnea or hypopnea, usually not occurs. So in this case, there is only nocturnal hypoxemia in COPD patients, and but the apnea and hypopnea is very less, around 5. So FEV1 ratio is less than 65% in this patient. In PFT, borderline desaturation or hypoxemic, they have worse survival, and in these cases the chance of the pulmonary hypertension, right heart failure are more, and if they fulfill the criteria for LTOT, give the oxygen. This is the sleep related hypoventilation, but AHI is usually normal. 43% of the patients with the decompensated hypercapnic COPD patients has sleep related hypoventilation. Sleep study has to be done. Here the total sleep time with saturations of less than 90% is more than 30%. That is, patients is usually in a long period of the desaturation, and instead of the characteristic sawtooth like desaturation, prolonged sustained hypoxemia for 5 minutes or more is here present, and low mean saturation of less than 88 or less. Limited data, but the nocturnal NIV or oxygen in symptomatic patients will relieve the daytime hypercapnia also, and CPAP if there is only nighttime hypoventilation. Here there is marked desaturation, that is the prolonged desaturation occurs. This is mainly the hypoventilation. The case for the last case, this is 64-year-old male smoker with dyslipidemia, BMI 28, previously diagnosed as OSA and referred for the daytime sleepiness. Initially the AHI was 15.8. In 2018-2019 PAP titration, there is good response to the CPAP of about 6 cm water, 54 minutes of the sleep including the REM supine position, and in summer 2022 another provider started him CPAP based on the 18 and 19 study results and ordered the PSG which was performed, and feels he is sleeping better, but there is no improvement in the daytime sleepiness. Epworth sleepiness scale is 18/24. Irregular schedule, difficulty in falling and staying asleep, estimates that he gets 3 to 6 hours of sleep per night and works as a school teacher during the last visit. So what are the assessment next step and any special consideration in these cases? Here AHI is very low. There is desaturation occurs and arousal is there. Total sleep time is 344 minutes, sleep efficiency is 81%, sleep latency 11 minutes, and the sleep stages are the these are the sleep stages, mainly the N2 stage, position 65 minutes supine, 2078 minutes on the left lateral, and AHI is only 5.2. So this is the another sleep study. This hypopnea is very low, only these, so the AHI is only 5.8. And PSG result, efficiency, sleep efficiency 83%, CPAP titrated from the 6 cm to 8 cm, now the AHI is 0. This is the multiple sleep latency test also done for this patient, and the NAP 1, 2, 3, 4 these are done, and there is mean sleep latency is less than 1.8 minute. What is the diagnosis? This is the narcolepsy. It is the second most common cause of the daytime sleepiness. First is the OSA, and onset typically teens and early 20s, but can be after the age of the 40. This may be with or without the cataplexy, and pathology of the narcolepsy and the cataplexy is the loss of neurons that produces the hypocretin. There may be the wake promoting, stabilizing wake or sleep inhibits REM, and it is without cataplexy is less well understood, that is the N2 narcolepsy. So there is excessive daytime sleepiness, fragmented sleep, REM related phenomenon like cataplexy, hypnagogic hallucinations, sleep paralysis, these are present. And here, not only the polysomnography, but the multiple sleep latency test has to be done here. Before that multiple sleep latency test, the PSG should be done before that. And what is multiple sleep latency test? That is 4 to 6, usually the 5 opportunities to nap every 2 hours and 20 minutes to be given to fall asleep. If fall asleep and allows the 15 minutes to sleep, and then the patient is aroused. And the data obtained, number of the naps in which the sleep is obtained, mean sleep latency, and if no sleep, 20 minutes for that nap. So the sleep latency is here usually less than 8 minutes, and the number of the sleep onset REM should be detected. Here the mean sleep latency is less than 8 minutes, and the number of the sleep onset REM should be more than equal to 2. And in cases of the cataplexy is present and this excessive daytime sleepiness, then the diagnosis of narcolepsy can be easily done. Here important thing is that in narcolepsy this is very predominant cause of the excessive daytime sleepiness. Here we can have a normal PSG also. In this case the multiple sleep latency test has to be done. Treatment, wake promoting agents like the modafinil or R-modafinil can be given, amphetamines can be given, and REM suppressing drugs, this can be given like the venlafaxine, fluoxetine, tricyclic antidepressants, or the GABA analogs can be given. Something about the restless leg syndrome. What is restless leg syndrome? Patient has restless leg during the sleep. Initially, when the patient is awake, then or patient moving his leg or arms, there is no problem. But when the patient is in rest, there some unusual sensations happens. This is called the restless leg syndrome, and this is also correlated with the periodic limb movement disorder also. And in these cases, we should detect it by polysomnography, and in this case we will detect the multiple sleep latency test. Usually it may be genetic, it may be associated with the iron deficiency anemia, so the ferritin level should be detected. And here the pramiprazole can be given, and the symptoms not only so these are the features. Here this is the rest leg, this is the limb movements, these high limb movements are there during in the PSG. Here also the limb movement, that is the leg movements are present in the PSG, but the AHI may be normal. So I am ending here. These are the cases and why the polysomnography is important. Thank you everyone for your patient hearing.
Thank you, sir, for your wonderful talk on sleep study or polysomnography. I think we have delegates or attendees for the workshop would like to ask questions regarding this sleep study or how to interpret the study results, if any. If there are no questions, I'd like to ask one question, sir. Arjun sir has a question.
What are the indicators based on which we can recommend CPAP? What are the indicators from the sleep night study parameters, the titration parameters?
Important is that we should there are some indications, that is patient may have excessive daytime sleepiness, patient may have frequent awakening at night, along with the loud snoring is there, then patient has difficulties in
for the indication for recommending CPAP.
Oh, sorry, sir. Recommending CPAP, if this AHI, we should detect the AHI. If the AHI shows the moderate to severe obstructive sleep apnea, that is AHI is more than 15, we can recommend it, provided that patient does not have any mouth problem or any facial problems. In cases of the facial problems or mouth problem, we can this mask will not be properly fitted. we should do the polysomnography. Based on the polysomnography, we can detect it. We can give the CPAP.
Any parameter based on the improvement after giving the after going through the titration phase?
This titration is needed.
Improvement of saturation, I mean.
Usually during the titration, CPAP titration, we are using the oxygenation. That is the SpO2 we usually measures. Because full polysomnography usually not done regularly, but the level 3 or level 4 studies can be done during the sleep CPAP titration. And another thing is that the oxygen saturation helps. This oxygen saturation indicates there is improvement of the oxygen saturation with the CPAP. And the CPAP machine will indicate also the number of apnea and the hypopnea when the CPAP titration is going on. By this way, the number of apnea and hypopnea by the oxygen saturation, by the sleep time, total sleep time, by the sleep latency, we can have an opinion that is the patient is tolerating the CPAP well or not.
So there's another question for people have different sleeping times. Some people sleep at 11, 12. Most of the medical residents sleep after 12 in the night. So the sleep study begins at 12 or the time you sleep?
It is about the patient's prerogative. It is not that it has to be started on 11. And when the patient usually sleeps, the sleep study and the patient, when the patient is usually awake, sometimes like me usually sleeps at about 1 and usually wake at about 8. Slow sleep study is done according to that.
According to the timing of sleep of that person.
That's why it should be done in a sleep laboratory, so that the things can be changed according to the patient.
And is it really easy for a person to sleep in a laboratory, not on his own bed, with all the electrodes?
It is very difficult. That's why I have I have given a slide that is the limitations of the PSC. That is a first night problem. This is definitely a problem. And sometimes if the patient has any definitely in problem during the lab, then we will use the home sleep study also. That is the level 2 study.
Thank you, sir. If there are no further questions regarding sleep, I would thank our speaker for this wonderful talk, and we'll give a loud round of applause for him. And I would request Professor Ashish Basu sir to felicitate our speaker, Dr. Chaudhary, for his wonderful talk on polysomnography. A big round of applause for our speaker. Thank you, Dr. Chaudhary and Professor Basu. Without wasting any further time, we'd like to move on to the third and one of the most important talks today in endocrinology purview, genetics in endocrinology. And can I have the CV slide of our speaker for the third workshop? And we have an outstation speaker for this talk who has kindly consented to guide us through the genetics curves of endocrinology and how do we test, what do we test, and how do we interpret the reports. We have to deliver this talk Dr. Sheetal Sharda, and the CV is right in front of you. She is a DM Medical Genetics and she will be delivering the talk on genetics in medical endocrinology. I would request all the delegates who are outside in the lobby, maybe if you've enjoyed your cup of tea or coffee, to please come inside the hall so that you can be guided better when you order your next test of genetics. And the other two housekeeping announcements remain the same. Please do not forget to collect your participation certificates at the end of this session, and dinner, of course, at the end of all the sessions. Thank you. And please stay back for the inauguration of the CRESCENDO, official inauguration of CRESCENDO 2023, right after this talk. Sharda madam, please. Yeah. Could you load the presentation, please?
You have loaded the wrong one. No, this is not the slide. This is not the presentation. Yes, sir. Sorry for that. Okay, so we'll not waste time. We'll just start with questions. Majority of you all are here, I think, MD, DM students. So if you can share your experience with genetics, what exactly do you understand when you use the word genetics or genomics? Can anybody be bold enough to answer that question? So what comes to your mind when somebody says genetics? Are you confused? Are you annoyed? Are you happy that you have heard some word? Or do you think it is just a jigsaw puzzle thing and a very challenging, complicated topic? How many of you in MD Pediatrics read that chapter on genetic and metabolic disorders in Nelson? Hands up. Only one. And you're sitting in the front. Good. Okay, anybody from the back who read that chapter on genetics and metabolic disorders? So it was a 10-mark question, right? Okay, so now I know my audience. None of you are interested in genetics much, but unfortunately this is an era of genetics and genomics, so you definitely need to be aware of you should be aware of what genetics is, what genomics is. Yes, I think this is the presentation. The last one. Right, so, fine. So that's the right PPT which I wanted to present today. So today we'll be learning about the role of genetics, genomics in clinical diagnosis and how it is making a difference in what you already know. So as clinicians, we pay more attention to the clinical findings, we send the routine laboratory test, and we do certain special tests to give a diagnosis to the patient. But we all know the limitation that at some time or the other, we are caught up at what exactly are we looking for. So mostly these disorders are where you are suspecting an inherited genetic disorder. So many times you might be asking a family history. So the first test which you do in a genetic disorder is draw a family history, which is known as a pedigree. So for all useful purposes, you ask certain questions to the family members that is this the first child who is affected? Are there any siblings affected? Are there any cousins affected? Is there any consanguinity? Or if you can take maybe 2 or 3 generations, whether there is any other family member who has a sort of a similar disorder or a phenotype which you have in front of you. And based on this pedigree drawings or what is known as the inheritance patterns, you can know what type of disorder you are looking into. So these are the major common Mendelian mode of inheritance which you may come across in your OPD basis. So you may have an autosomal dominant disorder. Autosomal dominant means that even if one gene, we all have 2 copies of the gene. One comes from the mother, one from the father. So even one copy, if it is affected, you are going to have the disease. And the risk of recurrence is as high as 50% in the next generation. So a person who has a disorder is going to pass it to their kids in the high risk of 50%. Then there is what is called as autosomal recessive, in which both the copies on the chromosomes from the mother and the father have to be abnormal to give rise to a symptom. So in that you will have a horizontal mode of presentation, means many members of the same generation will be affected and their parents or their upper generations are usually carriers and asymptomatic. So whenever you are looking at an autosomal recessive disorder, you should be having 2 abnormal genes. Then comes the mitochondrial inheritance, X-linked dominant, X-linked recessive, and then there is certain things where you cannot explain the exact mode of inheritance. So you are suspecting probably it could be chromosomal or a complex disorder. So once you know based on the family history or you draw this pedigrees, the thing is, okay, you have you have red flag that this is a genetic disorder. So the dilemma occurs is what types of tests are available to confirm this diagnosis, right? So this is a dilemma which we are facing because it's just been, I think, a decade since all these genetic tests are cropping up left, side, right, center, and we don't know what to do about it. So are all disorders tested by one single test, or there are different tests available? What is the interpretation? So first, when X-ray came, we learned about X-ray, then the USG came, we learned about USG, then CT scan, then MRI, then PET, then SPECT, and everything just shows that the resolution is improving, the technology is improving, and you're getting more and more information from whatever technology we are using. So this interpretation of genetic reports is the same, that as the technology and information is improving, we are getting more and more diagnostic yield out of it. And then the biggest question comes that we have suspected a genetic disorder, but the report is negative. Does it mean that this is not a genetic disorder, or are we missing something? And the parents will definitely ask that you have done this. Does it change my treatment? Does it change the management? Does it help in prevention? So all these questions can be answered if you send a genetic test, but you have to send the right test. So for that, we have to understand the basics of genetics. So we all know that we have the cell, we have the nucleus. The nucleus is the house for the DNA material, which is stored on bodies which are known as chromosomes. So chromosomes are large houses which are storing your DNA or your genetic code. And then this DNA, or what is known as a genetic code, is going to translate into a particular protein. So whatever you're testing in your patient by blood test, by serum test, by urine, they are basically the metabolites, right? So you may do a hormone, you may do an enzyme assay, or you may do MRS spectroscopy, whatever. These are just the final products of your DNA code. So the central dogma of life, again, this is more of an MBBS thing, that your DNA is being transcribed into our RNA, and the RNA is translated to a protein, and the protein is going to give the function to your body. So whether your eyes will be, green or blue or brown, or whether you are going to get a cardiomyopathy or you are going to get a muscle disorder, ultimately depends on your gene of interest and how it is being translated into the final protein. So the whole genome, or what is known as the clinical genome, information depends on not only the genetic code but also on proteomics, transcriptomics, which is ultimately going to lead to the phenotype. So all segments of pediatrics or adults now use genetic studies to confirm the diagnosis, and it is across all segments. It is not that neurologists are more benefited or fetal medicine are more benefited. Now every segment of medicine is benefited by doing a genetic testing. So how does your DNA code look like? Nobody will be able to interpret what this is, but it doesn't come like ATGC, because these are just nucleotides. And 3 nucleotides together will make 1 amino acids. Again, MBBS, not even MD. So you have 3 nucleotides, A, and anything of G and A will give rise to a amino acid which is lysine. So this is the first codon, AAT or AAG, and it will give rise to a protein known as lysine. So in this way you can see just 4 of these nucleotides can give rise to 64 amino acids. And based on the 64 amino acids, the proteins are going to be formed. So any change in this code will give rise to an abnormal protein, right? So what is this abnormal code? So the code can happen at a single nucleotide level, like instead of, this is the original sequence, so AATAGCC, this is the original sequence. But if there is deletion of a single nucleotide, it is known as a single nucleotide deletion. You can have an insertion, means there is an extra A here. You can have a duplication, that this whole thing is duplicated, like 3 nucleotides are duplicated. Or you can have a substitution, so instead of a A, you are having a G. So this is known as single nucleotide variations. But when you talk of larger deletions, duplications, they come into the category, of copy number variations. So you can have large deletions involving more than one gene. You can have large duplications, you can have segmental duplications, and you can have insertions. So these are known as copy number variations. So when we do a genetic test, we have to ensure whether we want to look at single nucleotide variations or copy number variations, and depending on that, you have to choose the test. So this is just the basics. And then to test this, what type of technologies are available? So the most common and the most gold standard, most orthodox test which we tell is the karyotype, chromosomes. So what we were told is just like a cardiologist does an ECG for every patient coming in his OPD, clinical genetist does a karyotype, but it is not so now. Karyotype also has very limited indications, but wherever it is indicated, it is the gold standard. So you can do FISH, which is a rapid test, again for chromosomal disorders, but it is for only known disorders. So FISH are probes which will attach to the segment of the chromosome of interest. So you can test only for trisomy 13 if you are using a probe for 13, 18, 21, X, Y, or Dijot syndrome, or you have to know what you want to know, and then the probes will be helpful. So for unknown disorders, FISH will not be helpful. For that, we have to do chromosomal microarray. So that is again a higher resolution test, as you can say, just like a karyotype which is doing banding, microarray is a higher resolution karyotype, which will check the copy number variations, or what is known as microdeletion, microduplication. So it is a higher resolution chromosomal analysis. And then there is a test which is known as multiplex ligation probe amplification, MLPA. So for endocrinologists, currently there are only 2 or 3 indications where you may have to send for MLPA. That one is Prader-Willi syndrome, which checks for methylation as well as microdeletions, or Silver-Russell syndrome, again because it is a methylation problem. So for 2 or 3 conditions, you have to be very specific that we want to do MS-MLPA. For rest, we are totally depending on sequencing. So the code which I told you, ATGC, can be sequenced base after base by a method known as sequencing. Initially we used to do Sanger, now we are totally dependent on next generation sequencing. So I will take each of these technologies, totally case-based method, and I will not be going into any theory, no details of the technique, right? So chromosomal disorders, as pediatricians, we all know that you have seen a child with Down syndrome, and there were 2 or 3 things which we always put. It was a checklist. Child with Down syndrome, do karyotype, do thyroid, check for cardiac, and then do a follow-up, right? But we know that a child with Down syndrome can have multiple endocrinal problems. So even if whoever diagnoses it, maybe a pediatrician, maybe a GP, maybe a cardiologist, but they have to come to an endocrinologist for so many of their problems which can be handled by an endocrinologist only. So karyotype is the first test to confirm. As you can see, trisomy 21. So Down syndrome is trisomy 21. The chromosome number 21 is triplicated. So instead of 2 copies, the child has 3 copies of chromosome 21, and that is known as free trisomy. But you can have Down syndrome due to other reasons. 95% may have trisomy, but 5% may have translocation or mosaicism, right? So in that case, it is important to prognosticate. Otherwise, rest of the things may be, variable severity based on what translocation is occurring. There are sex abnormalities, again, for which the test of choice is always a chromosome analysis. So you have a child with Turner syndrome, you have a patient with Klinefelter who is coming with infertility, or you have, I would say, ambiguous genitalia. The first test is a karyotype, because multiple mosaicisms or multiple abnormalities of the X or Y chromosome can be seen by a karyotype only. So as you can see, in Turner syndrome, it is not always 45X. It could be 45X plus 46XY. So when you have the Y chromosome, means it is a male determining factor. So the patient may present with a little bit of ambiguous genitalia. Similarly, you can have X and autosome translocation, you can have isochromosomes. So this is the P arm has duplicated. So this is known as an isochromosome. This is a ring chromosome. This is a partial deletion of the P arm. So the small arm is known as the P arm. And then you have a mosaic pattern with XY, or you can have multiple, like we have seen patient with 45X, 46XX and 47XXX also. So all these permutation combinations can occur, and it will not be picked up if you do a FISH. FISH will only help in early neonatal period, immediately after birth. If there is ambiguity, you want to label the child as male or female, because FISH will give you the result probably between 24 to 48 hours. And so at least to designate a sex, if you can do FISH, it will be the first choice. Otherwise, if we want to elaborate on what is the diagnosis in sex chromosome abnormalities, it should be a karyotype. So that is a patient with Klinefelter syndrome. And this is Dr. Somik's case, and we had quite some discussion on this, because this was a 50-day infant with ambiguous genitalia. There was no adrenal crisis, no dysmorphism, no skeletal. So a very well evaluated, worked up case. And the test of choice, it was XXYY. So for me also it was the first time. I have not seen in my 12-13 years of genetics of XXYY or a double male. So now it was that this was initially considered as a part of Klinefelter, so spectrum of Klinefelter, but then there were groups who said that no, it has to be identified as a separate syndrome and it cannot be part, because they may present with behavioral abnormalities, tall stature, but they may also have ambiguous genitalia, which is usually not seen in Klinefelter syndrome. So yes, now there are groups, and there are, I think, very less few cases which have been reported with XX, YY. So we have to keep improving our literature by publishing such cases. The second test which I want to focus on is chromosomal microarray, which I told is a higher resolution karyotype. And it is again for known microdeletion, microduplication syndromes, but also for unknown, where you don't understand anything, but there is multiple system involvement, there is dysmorphism, intellectual disability, and you feel it is not fitting into something which we know already. You can send for a chromosomal microarray, because large microdeletion, microduplications will only be picked up by a microarray. So as endocrinologist, a child with 22q deletion or Dijor syndrome may not come first to you, because they have multiple other features. They may go to a cardiologist, they may go to a neurologist, but if the child has hypocalcemia, they may be referred to you for seizures or developmental delay. And then Williams syndrome is hypercalcemia. Prader-Willi, we all know, is obesity, but Prader-Willi, Angelman are part of the same syndrome. One is due to deletion in the maternal chromosome, one is due to deletion in the paternal chromosome, making it a part of one big 15q deletion syndrome, right? So the thing is, the more patients you see, so for me, Williams syndrome, I have seen only 3 cases till now. But I know that when I see a child with Williams syndrome, I will not have any other differential diagnosis, right? So as soon as you see the child, there are certain features. We all feel dysmorphism is very complicated, but you just need to compare it either with the parents or just feel that something is not looking right. But we cannot say your child is abnormal, your child is defective, your child is funny looking, your child is looking like it. So we have to avoid using these terms whenever we are discussing these cases in front of parents. But as soon as you see this baby, you see the chubby cheeks. For the parent, it is a good thing, my child is having such chubby cheeks. But the thick lips, along with that severe developmental delay, speech delay, cardiac abnormality, which is very specific as pulmonary stenosis. So if you have such dysmorphism, you know that you're looking at a microdeletion, microduplication syndrome. But since I had seen patients, I could make an impression this was Williams syndrome. I directly sent for a chromosomal microarray. I could have sent for a FISH, but till now, even I am not confident when I'm seeing a syndrome that I'm not missing something else. So I prefer sending a microarray because it will cover the other chromosomes and other microdeletion. So here we found a microdeletion on the 7q11.23. So this is how we, the nomenclature is for, can you see the arrow?
Yes, the big arrow.
No, not the big arrow. I just wanted to, Okay. So when we have a report, I am just explaining the interpretation of the report. So here they will give the size. So this is almost a 1.9 MB deletion on the chromosome 7. The arm is Q arm. So the smaller arm is the P arm and the longer arm is the Q arm, and then it is on the region 11.23. We don't say 11.23. We say 11.23, and it is a pathogenic variant, and it is abnormal because it is only one copy instead of two copies. So why I am telling you this? Because they again have lots of endocrinal problems. The patient might be referred to an endocrinologist for diabetes, early onset puberty and hypothyroidism along with hypercalcemia, which may need long-term therapy. So now is the role of multidisciplinary, multi-systemic involvement. So we cannot say this patient belongs to a cardiologist, this patient belongs to a genetist, this patient belongs to an orthopedician. Now is the time for multidisciplinary approach. You have to have a team to take care of such patients with rare disorders. For the parents, it is one child. For us, it may be multiple, but multiple referrals always tires them out. So sometimes you might get an unexpected result, because for this child who was just a 12-day-old female patient with severe hypotonia. So chromosomal microarray would not have been the first choice. The child was evaluated for spinal muscular atrophy. It was negative. The child was sent for whole exome. Unfortunately, they wanted to withdraw the ventilator, so they said that, okay, let us do a microarray just to be on the safer side. And what we got was a 15q11.2 deletion. So this is a region for Prader-Willi, right? So we always feel Prader-Willi will come with obesity, but now there have been lots of studies where they say that any child with early onset feeding disability or with severe hypotonia or failure to thrive, in fact, should be tested for Prader-Willi syndrome or sent a microarray. So here obesity will come later on. Initially they may have multiple other things for which a microarray can be the test of choice. So coming to molecular, so we have finished off with the chromosomal. So we have large aneuploidies, which were like Down syndrome, Turner syndrome, Klinefelter. We have looked at microdeletion, microduplication. Now we are coming at single nucleotide variations. So this is a much bigger, interesting topic. So just stay with me for some more time. So initially we used to do Sanger sequencing. So Sanger sequencing is very specific, it is very cumbersome, and it takes lots of time to sequence even a single gene. So now, due to technology experts and innovations in all fields, we have shifted entirely to next generation sequencing. Even if we want to do a single gene, we offer them next generation sequencing. So this is a result of the whole genome project. We should all be knowing about it, because it took almost 13 years to complete project for one whole genome sequencing, 13 years. Right? And still the work was not complete. It was just in last year, March, that they said, okay, now we have completed the whole genome. We know that we do not have 22,000 or 24,000 genes. We have less than 20,000 to 19,900 something genes we have, not even 20,000. So now they are saying 100% we have done it. So the scientists are saying we have finished our job. Now it is your job to take this bedside to the bedside. Use it as much as you can. Now we have all information about the human genome. And this is how the cost has come down so rapidly. So something which took 13 years and almost $3 billion, now you can all get it at $1,000. So this is, and you can get it in less than 12 hours, not 13 years, but 12 hours. And the Guinness Book of World Record is for 7 hours, 5 minutes. In 7 hours, they have sequenced the whole genome and given the result in 12 hours to that child in the NICU. So this is just the evolution of technology. It is nothing else. So somebody might be using an iPhone, somebody uses a Samsung, in the same way you might have Illumina, you might have Affymetrix. So these are just machines on which the work is done. The most important is how you are analyzing this data, which you are going to give to the patient. So what is the clinical validity? Whatever platform you use, it is high throughput, massively. So 20,000 genes sequencing at one time, that really takes a high throughput technique. So how do we apply this NGS in our day-to-day clinical practice? We are not even talking about research, this is clinical diagnostics. So there is something which is, the whole apple, the whole genome, but it is huge to sequence, giving a lot of data for which possibly we do not even have servers to store so much of data. So what we have come to a balance that let us just do the exome. So exomes are part of the gene. As you can see, this is the gene, so there may be introns and exons. So when we do the exons, we are doing the coding area. So the part of the gene which is going to make a protein are only sequenced. So that is only 1%. So if you are doing 1%, the cost is also 1%, the data is also less, so everybody is a win-win situation. So you are going to sequence 3 billion base pairs, you can do the whole genome. It's not that we cannot do, but there will be lot of information for which we may not have enough literature. You can do whole exome, you can do clinical exome, which majority of us have been doing on for such a long time, 4-5 years I think, and then we can do targeted gene panel. So you have a child with maturity onset diabetes of the young. You don't want to do the whole exome, you don't definitely want to do the whole genome, so we just do a targeted panel, but we'll be choosing limited genes which cause MODY as per the literature today. So if tomorrow you are sending the report, you might be missing one gene. Right? So for today, whatever literature we have, we will be using that targeted panel. You might miss some genes. So we are doing single gene also, gene panels, clinical exome, whole exome and whole genome, everything is possible. So if you are very specific that this is what I am suspecting, you can send for single gene also. So coming to endocrinology, now this was just the basics of what tests are available, what can be done. So when it comes to endocrinology, how can we utilize this information? So first of all is your clinical classification. Based on the presentation, based on whatever test you are doing, you are going to classify your disorders in one of these segments. And then it becomes easier, right? If you want to look at genes with DSD, we know that there are around 100, 200 genes which we need to focus, and we need not focus on the other 20,000. So the main important thing is when you have a child, you have to first classify into whether it is syndromic versus non-syndromic. That is how we as clinical geneticists do it, but you also can do it in the same way because it becomes easier for us to choose the genes of interest. So if it's non-syndromic, then, and if it is monogenic, then you have a list of genes. But if it is non-syndromic and polygenic, means there are multiple genes involved, then you have to do a different set of genes. Similarly, if it is a syndromic form, it could still be a chromosomal disorder, just like I said, Prader-Willi or something. And sometimes you may have more than 2 etiology, not even the genes. The etiology may also be different, and then you will have to do something else. So first classify it based on your primary presentation. So whether it is short stature, whether it is obesity, whether it is diabetes, whether it is tall stature, just try to see whether the child is isolated short stature or does the child have features of skeletal dysplasia versus some endocrine disorder, right? So based on that, your further testing will go on. So when we are talking about monogenic obesity, so I will just take the example of obesity and talk about monogenic, syndromic, non-syndromic, and even microdeletion. So monogenic disorder, obesity due to LEPR deficiency, leptin receptor, right? So it will not present only with obesity, but it will also have hypogonadotrophic hypogonadism, short stature. So it is again a syndrome, right? And there are multiple genes. So when you choose that, this is all the clinician's role to find out along with obesity what else the child has. Once you find out what the child has, it becomes easier to choose the gene of interest, right? So the clinician's role is more than the lab's role in helping find the diagnosis. So, and then once you know the gene of interest, you can know whether it is homozygous or heterozygous, so autosomal dominant or autosomal recessive, and then the risk of recurrence will be accordingly. So this was a 6-month-old female, non-consanguineous, excessive weight gain for last 2-3 months. So at 6 months it cannot be exogenous obesity, right? A 6-month-old cannot overfeed herself. So probably this is more of a monogenic inherited disorder. Genetic testing was done and LEPR termination variant. So this is again interpretation of the report codon number 314 and a deletion leading to this protein change. Homozygous means both the genes on both copies are involved and it causes morbid obesity. So you have the phenotype and you have the gene of interest. This is another case, again a 10-year-old male, weight gain since 4 years of age, along with sleep apnea, diabetes, and here they had suspected leptin deficiency, but unfortunately we didn't get any variant. So it is both way around. Where you're suspecting, you might not get a variant. Where you're not suspecting, you might get a variant. So it all depends on your clinical phenotype, and so this is a 10-year-old male. So here it can be an exogenous or a polygenic mode of obesity. So what I am talking about polygenic is multiple genes have to be involved to cause the phenotype. Along with that, environmental also plays a call. So when we talk about when you get this inverted commas in or susceptibility to, it means that you are prone to develop obesity, but it is not 100% that you will have the obesity. So these are known as susceptibility genes. So this is a qualitative test. So multiple genes together can cause that trait or the phenotype. And these are the genes which are marketed as susceptibility genes. So they may not be individually responsible, but they may lead to obesity. So we have almost a 130 gene panel for syndromic and non-syndromic obesity till date. Now this is what is known as obesity syndromes, because along with obesity they may have other involvement also, most common being Bardet-Biedl and Prader-Willi. So everybody in endocrinology at least have these two names in their head when they see a child with obesity. Others may still be a little, rarer forms. But if you have Bardet-Biedl, you will always look for polydactyly. You will always look for retinal dystrophy. For Prader-Willi, they will not have polydactyly, but they have very small hands and feet, tapering fingers and small penis, and they are more likely to develop type 2 diabetes. So when you have these two syndromes, you try to send genetic studies to know. Now this is what they had expected. So they had suspected pseudohypoparathyroidism because of obesity. Along with obesity, if you see the features, there are these typical hands which have a small third metatarsal. So as soon as you tell them to make a fist, the third metatarsal, similar like you see in Turner syndrome. So when you see such types of hands and feet where thumb is broad or you cannot make a full fist, you have to suspect pseudohypoparathyroidism, right? Because they may have other syndromes along with obesity, and here we got a likely pathogenic variant in the genus. This is the most common and single gene. So if you are suspecting pseudohypoparathyroidism, this is the first gene which you can test for to confirm your diagnosis. Another case, again they had suspected pseudohypoparathyroidism. So as you can see, the gene will be same, the exon may be different and the mutation may be different. Right? So your phenotype should match your gene. The variant may be different in different patients. Now Bardet-Biedl is again very confusing. It has not 1, 2 but 25 genes which can cause Bardet-Biedl, right? So clinically you have diagnosed it, but molecularly which type it is you will have to check, because this is what is known as genetic heterogeneity. Multiple genes, they are causing the same phenotype. So it becomes important to send for a genetic diagnosis. Here you can see this is MKS gene, which is also causing Bardet-Biedl syndrome type 6, and this is on exon 3, and patient has all typical findings: obesity, intellectual disability and polydactyly. Rest of the features you may have to check it reverse. But now you have another patient who has also retinitis dystrophy or rod-cone dystrophy, but doesn't have polydactyly. So you have obesity and rest of the features which are matching Bardet-Biedl, but this is Elstrom syndrome. So this is the closest differential diagnosis for Bardet-Biedl syndrome, which is known as and so the gene is different. So this is known as a genetic heterogeneity. So sometimes you may have to go retrograde. What you suspect, you might not get in the diagnosis. So you have to retrogradely, so this is known as reverse phenotyping. So many times the clinician says, this is not what we are suspecting, why you have given this variant. But you can see that the variant is very good. Very good means it is causing termination. So any variant which is causing termination, then there is 100% chance of getting that disorder due to that gene change. But then now this child does not have any eye changes, but now you have got the diagnosis, so retrogradely you will have to evaluate the child by an ophthalmologist for retinitis pigmentosa. Okay, so here this was another case in which two siblings in the same family, one had polydactyly, the other did not have polydactyly. Right, and the mother was already pregnant, so this was always a dicey situation because once pregnancy sets in, we don't have much time to evaluate the patient more. So here we send the male and female together. This could be the same syndrome, but we have seen cases in which in one family both the siblings can have different syndrome. Now how can you explain that one child has night blindness, polydactyly, increased weight gain, but the other does not have any polydactyly? But fortunately for this family, both the siblings had the same variant. So this is variable phenotype. In the same family, two siblings having the same gene change, one is having polydactyly, other is not having polydactyly. So this makes the counseling difficult also, and also we need to explain that this is variable phenotype. So when we do the prenatal testing, whether the child will have polydactyly can be seen on an ultrasound. But other things we cannot predict, that whether how much obese the child will have, how much intellectual disability the child will have, that we cannot predict. So variable phenotype is there. So prenatal was done and it was heterozygous in the fetus. Okay, so this is again a child with, the thing is we get confused when we get a variant of uncertain significance. So many of the clinicians have sent cases with 100% clinical phenotype. They are saying this is Bardet beetle, nothing else. But then we get a variant which is known as uncertain significance. So the gene is correct, the phenotype is correct, then why you are putting it as VUS? So here the thing is the gene and phenotype is okay, but the variant, if you check, it is a synonymous. Synonymous means in spite of the G being changed to A. So the G nucleotide has been changed to A, but the protein change is same. So it is the same change in the protein, so it may or may not cause the disease. So that's why it is a variant of uncertain significance. But the pregnancy also, they did the prenatal taking informed consent that we are not sure, but they still did it. The variant was not detected, but postnatally at least the child doesn't have polydactyly. Rest of the things we will have to see on follow-up, whether we are really looking at this gene variant causing this disorder or not. So this is where, you know, there are certain limitations for the variant classification which we have to follow the ACMG guidelines. So these things are new, we have to follow certain recommendations, otherwise every variant will be pathogenic and every prenatal testing is done and every child is terminated. So to prevent all that, we have to follow certain consensus guidelines that they are classified as what will be called a pathogenic variant, what will be a likely pathogenic variant, and what will be a variant of uncertain significance. And there are two more, benign and likely benign, that are already filtered out by the lab. You will not even find it in your report. So it is just a juggling between these three variants, and the report is reported accordingly. So it may not be that if we follow these guidelines, then there is reciprocation. So every lab will have to give that variant as pathogenic if it has been classified accordingly. So along with VUS, as I told, sometimes you may get a negative report. So either we have not done the right test. That is the biggest question. Have you chosen the right test? Second is there is limitation of the technologies. There are certain areas of the gene which are very complex, right? Deep intronic regions or promoter regions or high GC rich regions which cannot be tested by the current technology which we use for exome sequencing. But in near future, if we start using whole genome, then probably these limitations will be cleared off, and the rest of the 20% where we don't get any reports or we get a non-report will be cleared off. So, as I said, for Prader-Willi, the test of choice is MS-MLPA. So, if you send a whole exome, you are going to get a negative, until and unless it is a deletion. So, for Prader-Willi suspicion, always send an MS-MLPA because it will check the deletions also and it will check the methylation specific reporting also will be done. So these both are the most common etiologies for Prader-Willi which will need to do a MS-MLPA. So probably your test of choice has to be checked first. And more important because the risk of recurrence will also depend on the test. So it's important to choose the right test when you are suspecting something. And sometimes you may not get a diagnosis in spite of a very typical phenotype. So this child had, very typical facial dysmorphism, holoprosencephaly, and severe obesity of childhood. We can classically mark what the child has, but in spite of doing a testing, we didn't get any diagnosis. And this was just a clinical diagnosis that it is Momo syndrome, which is macrosomia, obesity, microcrania, and ocular abnormalities. So, they just club together most important findings and make it into a syndrome. And it is surprising for us because till now, we have not found an etiology for this syndrome. I think people are getting either I'm not very clear or okay, or I'm beyond my time, one of the other. So if time is going out, I can stop. Okay, I still have lots of time, okay. Okay, so sometimes we have to go back on literature because we are not only dependent on diagnosis, we are also wanting a management. We want treatment. The patient has come to you for treatment and not only for telling, oh, your child is very fat, So for obesity, yes, whether we identify a treatable cause, it will become a personalized medicine for that family. So there are many studies, many review articles where you can find that based on the gene of interest, there are certain treatment options available. So instead of, we cannot tell a 10-year-old child to not eat junk food or do exercise or whatever, there are so many changes we need to be done. But if you give a drug, the parents also feel satisfied and probably they may have a good response. So this is the importance of doing molecular testing. It is like, yes, you are spending money, but a long-term treatment option also can be given. So certain things may not be treatable, like if blindness is there, hearing loss is there, it will not be treatable by the drug, but yes, the obesity can be treated. So based on the gene of interest, you may have a typical drug which can be used at least for monogenic obesity syndromes. Coming to the second disorder, so obesity is out, we are looking at DSD now. Most common is CAH. Even in CAH or congenital adrenal hyperplasia, 95% of them will be due to 21-OHD. So that is a single gene, but I will not go, it's very complicated. I don't know how endocrinologists understand DSD. For me, even in MD, it was the most complex topic even today. So I'm not going to touch much on this, but just the genetics part little bit. So CYP21A2 is the most common gene. As soon as you suspect CAH, you have to send it. The only limitation being that it has point mutations also and deletions also. So ideal testing method is doing a combo. Means you do a MLPA also and do a sequencing also. And there are more than 200 mutations noted in CYP21A2. So once you send CYP21A2 testing, 95% of your cases of CAH can be resolved. Only in the rest 5% you may have a mutation in the other genes. So when you send for CAH testing, either you send single gene or you send sequencing for these 5 disorders together along with MLPA. Both can be done because then for those 5% also you can be screened in one test only. Right? So why 2 tests are needed? So I will just take one example. So this was a child who died in 2016. And then in the next pregnancy directly fetal sample was sent. So when you don't have the proband with you, there are limitations. Either you do the fetus directly. So the fetus was found to be a carrier of a single variant in this CYP21A2, which is a heterozygous. Now as I told you, autosomal recessive means you have to have 2 mutations, but you have only 1. The second significant variation was not found, yet they terminated the baby. They said we want one pathogenic, so they terminated. Now this is a very complex gene. So if you start reading CYP21A2, it's a very complex condition because of recombination between a pseudogene. So not again going into details. So in 2018, so this is the third fetus now, and they again directly sent for the fetus. And the same mutation was found, but this time I insisted that let us do MLPA first, right? I want to do it in the father because the mutation which was found in the previous child was in the mother. So the father had a deletion. So now we have to check whether the fetus has this mutation which is there in the mother as well as this deletion which was in the father. Only then your diagnosis is confirmed. So fortunately the child only had the heterozygous mutation and did not have the deletion. So in this way now we are confirmed that this is a carrier fetus and they continued with the pregnancy. So always insist on getting the second variant if you are looking for an autosomal recessive disorder. Again here, 2 siblings died, current pregnancy, what to do. So we did the carrier screening. So you can see even if you don't have the probands available, still we can give a prenatal diagnosis for the family either by doing the parental testing, right? Or we can test the fetus, but for that you have to have a very good confirmatory result. So either you give a 17 OHP level or you give the photographs of the ambiguity or whatever, only then it will be a direct testing. Otherwise always do the parents first and then we can do the fetus. So these are different genes associated with DSD. So this was X46XY with pinoscrotal hypospadiasis, and as you can see the gene SRD, where did this go? SRD582 causes a disease which is pseudovaginal perinoscrotal hypospadiasis. So it is matching your phenotype, right? So this clinically you will never say that this is a SRD5A2 phenotype. You will say it is XY-DSD, but a molecular diagnosis confirmed that this is a single gene homozygous mutation. Again, this is again a very interesting topic, why we need to do a detailed phenotype match. So this sample was sent for small gonads. We got a variant which causes something which is known as optic nerve hypoplasia and abnormalities of the central nervous system. Now they have not mentioned anything about this. So when the report went out, and that's why it is given as uncertain significance, because what they have sent we have not found, but still it is a termination variant. So when we went retrogradely to the clinician and got additional details, the child had an ophthalmia, microphthalmia, and MRI was also abnormal. So we should not have a pinpoint vision, right? That the child, I am an endocrinologist, so I will look only at the endocrine. You should have certain, your pediatric training should not go out, that we are finding how can somebody miss an ophthalmia, right? So yes, a neurologist might have seen, an ophthalmologist might have seen, just try to get the records before you send the samples. Okay, I have already talked about MODI, but it is just that it is again one of those evolving topics, right? Maturity, so it can be diagnosed both ways. It could be somebody makes it type 1, somebody makes it type 2, but there are certain genes which are very typical for MODI. There were 25 genes around 4 to 5 months back, years back. Now I am not sure how many more genes are there. But yes, again, personalized medicine, because based on your gene of interest, you can change your drug, right? Whether you want to give insulin, you don't want to give insulin, you have to give sulfonylureas, you have to go give high dose sulfonylurea or low dose. Everything will matter if you get the right gene in your genetic diagnosis. So yes, personalized medicine again plays an important role in these complex disorders. I was talking to one of the faculty outside about hypercholesterolemia, LDLR. So this is familial hypercholesterolemia type 1. Again, you can see that you can have either a single nucleotide variation or you can also have a copy number variation. Advantage of doing whole exome is that we also do for copy number variants according to the pipeline. So you may pick up a deletion also. So the genetic testing algorithm is very easy. first is always clinical features. Shortlist all the clinical features head to toe. You use your supportive lab assays, get your family history, and then a differential diagnosis, whether you are looking at a single gene or a multigenic disorder, whatever, and based on that, you have to choose your test. Right? So most important for clinician is this part and giving a differential diagnosis to the lab, and you can always discuss with the lab that what is the right test of choice. Rather than sending a sample with the test and doing a wrong test, always have, like you should have some clinical geneticists in your group or your team who can discuss the case and then decide what is the test of choice, because whether to send for a single gene or a gene panel or an exome or a whole genome ultimately will depend on your clinical phenotype. So try to evaluate the patient before you send the sample. Most importantly, don't miss out on the common diagnosis. This is MBBS, MD dogma that try to rule out the common causes first. So this is a case which was sent for skeletal dysplasia, but all the clinical features fit into caudal regression syndrome. So you may or may not get a diagnosis based on an exome because of a strong family history of maternal diabetes. So this lady has lost one child. During second pregnancy, she was diagnosed as gestational diabetes and she was given insulin, so this baby is okay. But during the third pregnancy, again, mismanagement, or she didn't report herself. Her HbA1c was almost 8%, but it was very late in pregnancy that they detected a CTEV. So this is probably a case of diabetic embryopathy. So we do not have to miss out on the non-genetic causes for any malformation. Take a good history and you will get, probably this lady has progressed to NIDDM based on the current features. So just summing up, final 2 or 3 slides, I have almost covered, except for congenital hypothyroidism, I have covered all large segments. I have emphasized on the balancing between the routine testing versus the genetic testing. I have also emphasized that there is no single test which can give all the answers. So basically we are trying to just do a jigsaw puzzle, as many clues as possible to get to the final result. So it all lies in genetic literacy. You have to prove that the disease or the gene which you have found is validate and the utility. So if it is not going to help the patient in any way, whether you really want to go for the test or not, I'm sorry, this animation didn't work. But this is the importance of pre-test and post-test counseling in sending genetic samples. Thank you very much.
I'd like to thank our speaker for this extremely interesting and engaging talk, where she has touched upon, I believe, most common aspects of endocrinology. And since we order genetic tests so frequently in endocrinology, it must have been useful for everyone, particularly the residents. Now, if there are any questions, particularly from the DM residents, I'd like them to please move to the nearest mic and ask Madam whatever has been your diagnostic dilemma of late. If you found any case difficult to diagnose, if you found any report that you couldn't interpret, if there are any queries of your patient or patient party that you couldn't answer based on the phenotype or the genotype, you're free to come and ask questions. Dr. Aditya has a question, I believe.
Any cases of VUSs?
Ma'am, I have a very basic question. The way we represent the pedigree chart, that is usually for Mendelian pattern of inheritance. How do we do the same for non-Mendelian pattern of inheritance? Let's say if it's oligogenic or if there are multiple genes involved, how do we go about representing that data on a pedigree chart?
See, pedigree is not dependent on modes of inheritance, Mendelian. Pedigree is just a family history in a diagram way. So you are just using squares and circles and triangles and relationship lines and ship lines. So pedigree drawing has nothing to do with Mendelian. Pedigree is just your family history which you are asking from your patients, and you draw it, you color it. The difference being that if you are the proband, the affected person has to be colored, shaded. Now we have colored pedigree drawing tools. So if one patient has 4 different problems, diabetes, obesity, you can give 4 shades. and then you can mark the father or mother. So many times we have a history that the child has diabetes and one of the parent has it. So you can use the same shade for the father, that he also has diabetes. And below that you can just write age of onset. Same we do for cancers and everything. So we just do different shades.
Let's, for example, let's say that the patient that we are looking at, he has 2 mutations, okay?
Yes.
And we screen the parents, and let's say that the mother has one of these mutations, does not have the disease. So how do we represent this data? That was...
So usually the pedigree is the phenotype, the external features. If you want to do the genetic testing, then below that you have to write the variant or gene name. So if the child is having 2 and the mother is having 1, means she is a carrier, right? So she will not have the disease. If it is an autosomal dominant disorder, in which the mother and the baby has the same variant, baby is affected, mother is not affected, means either it is an incomplete penetrance. So the mother is having the gene and the variant, but she is not expressing it. So that is known as incomplete or reduced penetrance. So you can always write, you will not need to shade it then. So that, and then, but if you ask the 3rd generation, you might have one of the parent of this lady who might be affected. So this is known as skipped generation. A little bit phenotype you will find. The thing is, when we have multi-systemic involvement in a disorder, the mother will be having some other symptom which we have not seen. So mother is not brought to you, she may have capillate spots which you have not examined. So it may not always be true that the mother is asymptomatic depending on the condition. So if she has single mutation in autosomal recessive, she is carrier, so the other mutation has come from the father. That we need to prove.
Thank you, ma'am.
Ma'am, your MODY panel, MODY panel, it looks into different genes including the HNF1B.
Yes.
And 50% of MODY5 is due to microdeletion of 17q12. So how do you pick up that microdeletion by doing NGS?
Okay, so now the pipelines or the bioinformatic pipelines have improved. So what we check, like in a microarray or MLPA, we are able to do in NGS also. So if there is a large heterozygous deletion, especially if you know what gene we are looking for, we just check the ratio of the coverage of that gene across 5 samples run simultaneously. So if that coverage of that gene across that gene of interest is low and it comes less than 50%, we say it is a heterozygous deletion. So homozygous deletions are very well picked up. Heterozygous deletions, it is still that we pick. I had shown one hyperlipidemia wala gene. So we can check CNVs in NGS. It should be more than 1 exon deletion. So that can be picked up.
So can you pick up 100% cases of
70%.
HNF1 beta deletion by your MODY panel?
Yes. I think so. 70% is our pickup rate, but I am not sure about this particular HNF1 which you are talking about. I can take a look at my internal database and let you know. I think if it is more than 1 exon, then heterozygous, we will definitely be able to pick it up. And then we always recommend that you do a confirmation by a validated method. Though we have done it in around 150 cases, we still recommend that NGS is not a gold standard. So if you find a CNV, always validate it with a more gold standard like MLPA.
And second question is, if the, say for example the clinical findings and the biochemistry is pretty much suggestive of a particular disease and your reports come normal, so how do we go about that?
Okay, so I usually don't use the term normal, I use it negative. Because as I told you, there are certain technological limitations to pick up. So even now globally, if you say, there may be 20 to 25% of the cases of typical phenotypes which may go out as non-report. This is possibly because it might be a new variant, deep intronic variant, or a variant in a high complex like NCF1 which we see in CGD. Which is primary immunodeficiency. That first exon is not covered across any platform. So the coverage will always be low. So in the same way, if we do not get, then the problem is that it could be a variant which cannot be currently picked up by the technology. That could be one limit, if the phenotype is 100% matching.
Thank you.
Thank you, ma'am,
yes.
for a nice lecture. So one of our patient who has been supposedly suffering from glucocorticoid remediable aldosteronism, GRA, it is a chimeric gene we got in this case particularly. So when we send the patient for the panel of familial primary hyperaldosteronism, particularly for the GRA variety, they gave all the other variety, but they from a reputed lab, they said that we do not do chimeric gene analysis. So
it must be a somatic mutation. Did they say something like that? Is
so
it
there are two genes. One is the aldosterone synthase and another one is the 11 beta hydroxylase gene. So there is a mutations, there is a chimeric
fusion. There must be fusion, yes.
Yes. So this type of fusion we want to know.
Yeah.
So how can we get this, or what is the possible, because there is a therapeutic advantage if we give some amount of some other drugs.
So fusion genes, and if it is a known fusion gene, then
it's a known, yeah.
Then a fish is a better test. Just like for Philadelphia chromosome, which we do. So if it is so we have to make standardized probe for the end of those regions, and then we see whether they are giving a double signal or not. So that is one way for looking at two genes which are getting chimeric and making a fusion gene. So if I am getting you right, or I can just see a report and try to understand, because I have currently not, I might not be knowing much about what exactly you want. I can see the report and try to understand and then get to a better answer.
Okay. And another question is, any patient with childhood obesity.
Yep.
So here our the main notion is whether the patient is suffering from Prader-Willi syndrome or not. Usually in the common setting. So from your discussion, we can understand that initially we have to go for MLPA, and if the MLPA is negative, then we go for clinical exome or whole exome sequencing, right?
No, for Prader-Willi mostly the thing is either it is a methylation defect or a deletion.
Deletion, yes.
Both will be picked up by MSMLPA. So for sequencing there are less than 5%. For typical SNPRN or
yes, this is fine.
Yes.
But if the MLP is negative, that means it is probably you are not dealing with the Prader-Willi.
Methylation or deletion, then you can go for sequencing, but I would prefer going for a panel, not only for Prader-Willi gene sequencing.
Yes, panel.
Because it could be a differential diagnosis, it could not be Prader-Willi, it could be some other obesity syndrome. Right. So always either target for a targeted gene panel, or currently we are saying better go for whole exome. Because a CNV calling is better on a whole exome sequence.
What about methylation defects? That won't be picked up by...
In MSM, no, NGS will not. Whole genome might. In recent future, if you send for whole genome, yes, but not.
You have to do both.
Yes, so if time is not there, patient is coming from outside or pregnancy, better to send both together, or you can send one at a time. First do MSMLP and then you can go for sequence.
Thank you, ma'am.
Just in continuation to what Dr. Roy said, say for example 1 to 2% cases of Prader-Willi is because of imprinting defect. So can you pick up that imprinting defect?
Imprinting is due to methylation.
No.
The imprinting center defect you are talking about.
Yeah.
Yes, so if it is due to a sequence abnormality, it will be picked up by NGS.
So once the MSMLPA is, say for example, suggestive of Prader-Willi, fish is negative.
Fish is negative. Why did you do a fish?
So I want to look at the underlying disorder, whether it's deletion or maternal uniparental disomy or a imprinting center defect.
Acha, but that will all be picked up by MSMLPA. UPD will not be picked up until and unless you do the parental testing together. So you will have to send 3 samples, mother, father, child. UPD means the same part of that gene in mother is duplicated. So you will only know if you do the mother, father and child together. So UPD will not be picked up.
So what would be your sequence if we try?
Sequence will not pick up UPD.
No, I'm talking about the sequence of tests.
Okay, I'm sorry. I had mentioned it, but because of lack of time, probably I've skipped that slide. So if you go to gene, I'm sorry.
Can we have the presentation back on screen?
Prader-Willi is again very complicated. It's there on the screen. Yeah. So this is the sequence. So DNA methylation almost in 99% of the cases, MSMLPA when you do, you will pick up deletions, UPD only if you do mother, father together, and imprinting defects. Fish is only for deletions. So only deletions, so we don't do fish for Prader-Willi now. Then you can, if you send for chromosomal microarray, you will be picking up the deletions, but you will not be picking up the methylation defect. So that will be missed. And then see, just like I told, deletions and some UPDs can be picked up by SNP array. So this is one higher resolution SNP array where you are checking the SNPs or a single nucleate polymorphisms in again mother, father, child. So you have to check that part of the chromosome in the child is both from the mother and none from the father, something like that. And then you do the sequencing which is less than 1%. So just less than, so this is the sequence, and for this the best referral board is gene reviews. So whenever I'm stuck with how to go about a genetic diagnosis, I just check gene reviews. So they have a very nice flow of saying that what is the percentage of mutations which you will find by sequencing, what will be the percentage you find by microarray and all those things. So if you just go to the gene reviews, put your either disease of interest or gene of interest, you will get some table like this, and then you can decide which is the better method.
Madam, this pertains to some of the reports that we get from our NGS panel when we order an NGS test for our endocrinology issues. We sometimes get a combination of reports where the first report is pathogenic or likely pathogenic, and the second report is either likely pathogenic or a VUS. These two combinations, even we have seen combinations of 3 reports. So possible. If one of the likely pathogenic or the pathogenic thing matches with our phenotype, should we be happy about it and forget about investigating the VOS, going to a Sanger or something and declare the diagnosis just based on the likely pathogenic or pathogenic variant?
Okay. So here again there are 2 concepts, whether you are looking at an autosomal recessive disorder, X-linked recessive disorder, or an autosomal dominant disorder. So autosomal recessive disorders, if both variants are in the same gene, right, you are getting 2 variants, one is P, one is LP, but the gene is same or gene is different. This is what I wanted to ask. So if the gene is same, then this means this is a compound heterozygous variant. So one has to come from the mother and one has to come from the father. Then it is compound heterozygous. If the same variant is there, it will be homozygous. Again, one is from the mother, one is for the father, but they are the same variants. So this is what is known as alleles. Right? So if it is a same gene and you are getting 2 variants, then you have to check it in the parents by Sanger just to know that one is from the mother, one is from the father. Sanger is not for classification of the variants. Sanger is done to know whether there is segregation of the variants. We have seen cases in which 2 variants are there in the proband, but when we do the parents, both are coming from one parent. So that cannot be considered as compound heterozygous. That will not cause the disease because they are on the same allele. For disease, one has to come from one allele, one has to come from the other allele. So that's why. When you talk about the third, then I didn't put that case, but nowadays in genetic literature, there are dual phenotypes. Overlapping phenotypes, blending phenotypes. So these are new terminologies in which the same child can have 2 different disorders. So we had one child in which there were 2 variants for Wilson disease and 1 variant for neurofibromatosis. So this is not not known. It is now being, as we do more genetic testing, we come to know that a person can have 2 different genetic disorders also. So depending on the 3 variants which you have found, whether they are for a different phenotype altogether or they are for the same phenotype. Even in that there is a concept of blending phenotype, right? So there are 2 different genes, but they are causing the similar phenotype, but when they blend together, either they may exaggerate the presentation or they may modify the presentation. So you cannot ignore the variant if, so first criteria is it should be from a good authenticated lab. You should know who is analyzing and reporting the variants. You should have connect with the technical lead there. And then depending on that, you have to decide of those 3 which you have to ignore, which you don't have to ignore. VUS, again, if you prove it that one is from the mother, one from the father, sometimes the classification can change. Because according to the ACMG criteria, if we prove the zygosity, then we can reclassify the variant. So that is important when you discuss the more than one variant report.
In one of your cases, you reported as VOUS because the protein was normal despite there was a change in the base.
The synonymous one,
Yeah.
yes.
So do you report VOUS only if the protein is not unchanged?
No, for this we had reported it because it has been reported in one of the database again as VUS. Because somebody other lab or somebody also has got the same variant and they've put it out that this Bardet-Biedl syndrome, we found this variant. It was synonymous. Because somebody else has also reported it, we also wanted to report it. We cannot ignore it. But it is known in HBB, thalassemia. Silent mutations can cause thalassemia. So when you have proof that silent mutations can also cause a disease, then we can use it as a VUS because we are not saying it is pathogenic. We are saying that we cannot rule it out as benign, likely benign, but we don't want to report it as pathogenic, likely pathogenic. So for future reference, let's keep it in. So if for that second case, if the second baby was also affected, and they had the same variant, then it becomes a clinical significant variant, that two siblings affected with the same variant has the same disorder. So it could have been, that's why we reported it.
No, the reason I'm asking is that, say for example, my clinical diagnosis and the biochemistry is corroborating with a particular disease, and you have reported as VOUS of that particular gene. So that might be a novel one.
Yes.
So if I want to report that,
yes,
how do I go about that?
Okay, so there are 2 or 3 things how you can go about it. First you do, so if it is an autosomal recessive or autosomal dominant?
Say autosomal dominant.
Dominance, parents do not have it? Okay.
It can be a novel mutation?
Novel mutation, but see, if it is a very significant clinical phenotype and one of the parent has it and they do not have the symptoms, and it is known in literature that this causes complete penetrance, then that significance goes away. But if it is a de novo variant, means during the conception or during the making of the baby, it's his own mutation, not from the parents, it's its own mutation, then the mutation becomes significant.
So how do I prove that?
So first you do in the parents, that parents don't have
Parents are negative?
Negative. Second is, we have to do protein modeling studies. So
do you do that in your lab?
We don't do it. We have recently done it for 10 VUSs from somebody in Amity University, and we have proved by the 3D modeling that because of that variant, the protein structure is getting abnormal. So once you prove that, it becomes significant and then you can publish it if that is your main thing that you want to. Now what's happening, single VUSs, no journal is accepting it. So either you just put it out there as a letter that we found this variant, this was a phenotype, but these are the predictions. So now we have more than 25 predictions. But if you do a structural modeling, it will become a better proof.
Thank you.
If you have like a patient had a mitochondrial manifestations, mitochondrial gene, and also a pathogenic with regards to hearing from an autosomal recessive also. So multiple manifestations with 2 different kinds of, as you mentioned. So how do you report that then? Which is causing the...
Very difficult. If you want to report, you can report. It can be like both of them are having their individual effect. There could be a possibility of gene-gene interaction because many of the mitochondrial genes are ruled by nuclear mitochondrials, and mitochondrial genes itself have different interactions, right? So mitochondrial might be causing one phenotype and deafness might be due to the other phenotype, but there is no way to prove that mitochondrial is not having any effect on the, maybe because of the mitochondrial as well as that the child has a different phenotype. So it could be a blending phenotype, but we cannot prove by any way until we do functional studies of the local cells. So you will have to do something from the localized hair cells or something and prove that the mitochondria and that part is normal. So the somatic mutations need to be done.
And especially those for somatic, like in hyperaldosteronism, just as he was mentioning. So a lot of them are somatic mutations.
Yes.
So is there any way that's other than to pick them up? Because
somatic mutations are that your blood will not have it.
Yeah, that's the problem.
But you can use a localized tissue. So if you have like overgrowth syndromes, if we take an example, or skin changes, you can take a part from that skin and get it tested. For somatic mutation, we can do deep genotyping. So here we do 80 to 100x depth for germline. For somatic, like in cancers, we may have to go to a depth of 1000x.
Okay.
So that can be done because they will be very diluted in the blood. So if you do 1000x depth, you might be able to find a somatic mutation. So you may have to use two tissues. Just like mitochondria, it's better to do it in a muscle tissue than blood to get a diagnosis. So you can use a localized tissue of interest and do the same genome testing.
Thank you.
Thank you, ma'am, for that extremely interactive session. It was almost running in. We are running out of time, and we thank Sheetal madam for all the presentation and answering possibly most of our queries. If there are any more, we can discuss them off stage.
Yes.
Thank you, madam, for your wonderful talk, and I request Professor Pradeep Rai Chaudhary to felicitate madam on behalf of the Endocrine Society of Bengal and CRESCENDO 2023. A big round of applause for Dr. Sheetal Sharda. I would request everyone to please stay back in the hall for the official inauguration of CRESCENDO 2023. DME sir is on the way and will be here any time. And dinner will be available right after the inauguration, immediately after the inauguration in the ground floor in the dining area. Everyone is requested to please stay back in the hall while we prepare to inaugurate
Way back in 2016, today Endocrine Society of Bengal has more than 50 esteemed endocrinologists in this state as its members, and CRESCENDO has been the flagship program of the ESB over the years. Taking the program forward, I would like to invite the dignitaries for this evening now on the dais. May I please request Dr. Shubhankar Chaudhary, Chief Organizing Officer, CRESCENDO 2023 on the stage, please, sir. May I now please request our guest in chief, Dr. Debashish Bhattacharya, Honorable Director of Medical Education, Department of Health and Family Welfare, Government of West Bengal. Please, sir. May I now request Dr. Nilanjan Sengupta, Organizing Chairperson for CRESCENDO 2023 on the dais, please. May I request Dr. Shujai Ghosh, Chief Executive Officer, CRESCENDO 2023 on the stage, please. May I request Dr. Dasharathi Sarkar, Honorable Chairperson of the Endocrine Society of Bengal. May I request Dr. Shomik Goswami, Organizing Secretary, CRESCENDO 2023 on the dais, please. Thank you so much. Welcome to CRESCENDO 2023. Can we have the inaugural video of the CRESCENDO 2023 on the stage, please? Inaugural video, please. I would now like to take this opportunity to felicitate our dignitaries today. May I request Dr. Niti to felicitate Dr. Dasharathi Sarkar, sir. May I request Dr. Nisha to felicitate Dr. Shubhankar Chaudhary, sir. May I request Dr. Pankaj Singhania to felicitate our DME, sir. May I request Dr. Obronil to felicitate Dr. Nilanjan Sengupta, sir. May I request Dr. Preetham to felicitate Dr. Shujay Ghosh, sir. May I request Dr. Akshay to felicitate Dr. Shaumik Goswami, sir. Now we will have the inaugural song by Dr. Utshab Das, Senior Resident Department of Pathology at Calcutta National Medical College.
Good evening, everyone. Today I will perform few lines from our Rig Ved verse and then a line from Tagore's interpretation. Yademi prasfuranniva dhritirnad mato adriva mrira sukshatra mriraya yademi kratva samahadinata pratipang jagamashuche kratva samahadinata pratipang jagamasuche mrira sukshatra mriraya apam madhe tastivamsam ঝড়ের মেঘের মতো আমি ধাই চঞ্চল অন্তর তবে দয়া করো হে দয়া করো হে দয়া করো হে ঈশ্বর।
Thank you, Utsav, for that wonderful inaugural song. And as a token of appreciation, I'd like Dr. Sunetra Mondol to hand over a memento to Dr. Utsav on behalf of the Endocrine Society of Bengal and CRESCENDO 2023.
May I now request Dr. Shubhankar Chaudhary, sir, to kindly deliver the welcome address.
Very good evening. Very respected and our very own, very dear Director of Medical Education, Professor Debashish Bhattacharya, other dignitaries on the dais, Dr. Dashrathi Sarkar, Professor Niranjan Sengupta, Professor Sujoy Ghosh, Dr. Shomik Goswami, and all of you. A very warm welcome to this inaugural program for CRESCENDO 2023. We are looking forward to wonderful academics as well as getting to know each other, meeting friends, making new relationships. All of these are important sort of components of any medical conference. We have a wonderful scientific program lined up with a good mix of faculty, both local, national, as well as international. CRESCENDO has distinguished itself over the years as being a medical conference with a little bit of difference, having as USP primarily the academic content, which is not diluted by industry influence, but we do appreciate the help that we get from the industry as well. So let's all have a wonderful evening, and then the subsequent days ahead. We have CRESCENDO as the Endocrine Society Conference. Subsequently, we'll also have the RSSD and annual conference, which is all part of the same meeting, I feel. So let us have a wonderful learning together, and let us also hope that these translate into our better clinical practice. And of course, we do understand clinical practice is not just about using our knowledge or using science. It has to be done compassionately. It has to take into consideration the mental state of the patient, the socioeconomic background of the family. All of those go into us delivering better healthcare. So let's all work together for better health of our state. Thank you very much.
Thank you so much, sir. May I now request all the dignitaries led by our beloved DME, sir, for the ceremonial inauguration of CRESCENDO 2023 by lighting the electronic lamp. Chief guest, Dr. Debashish Bhattacharya, sir, to give the inaugural address.
Good evening, and it's really a pleasure to see you all here. And after the subsidence of corona, though it is in between flickering somewhere, some spots. but at least we can now meet physically. That is important in life. Because life has become virtual, and many of the areas particularly requires to be rechanged into the physical presence, because many of the occasions it is really difficult to translate and express the mental feelings and the caring through virtual mode. It is almost impossible, though AI is also taking care of these areas, though not very properly. However, regarding the crescendo, I wish and pray to Almighty that it really remains a crescendo, though in life crescendo and decrescendo requires to be there to make a wave of life. Otherwise, it is very difficult to remain in crescendo throughout the life. But all said and done, the Endocrine Society is really doing a good job regarding bringing up the newer generation, because all the senior teachers I know here, because I have worked with many of them as a fellow colleague, as an MSVP, as a principal, and presently as a DME. I know they are very capable teachers, and they are really bringing up their youngsters for future of Bengal, and if not the whole country and the world. So quite naturally, in these days, we really have to have a good hybrid technique of physical, mental, AI all together to give a newer aspect of endocrinology for future. And I always tell that endocrinology related surgery part also requires to be developed simultaneously, which is still in the progress. And I hope that I may not be able to see while in the chair, but I hope it will be coming very soon at SSKM with an institute where both the surgery and medicine will be together in endocrinology, and really we can develop it. I wish and pray that all of us really work for the society and be with the people, for the people, and really bring up India in the forefront. Thank you. Pranam.
Thank you so much, sir. Now may I please call Dr. Shomi Goswami, sir, to deliver the vote of thanks.
A very good evening and a warm welcome to Crescendo 2023. My special thanks and gratitude goes out to our chief guest, Professor Debashish Bhattacharya, who has graced this occasion, shared his words of wisdom, and made this occasion a really special one. We know that at the heart and soul of any conference is its science, and I believe that we have tried to bring the choicest speakers with the choicest topics from across the land. And I would like to thank Dr. Partho Pratim Chakraborty, Dr. Rana Bhattacharya, who has made this difficult job of selecting the best topics and the best speakers. Now, in any conference beyond science, there's an extra scientific area. And you could call it an unscientific area. So I jokingly called myself the extra scientific or unscientific secretary of the conference. And in this regard, I think the other person who has toiled more than me mentally, if not physically, is Dr. Sujoy Ghosh. And I would also like to specially mention Dr. Devmallu Sharnal, who has helped me in this part of the story. Of course, we had our seniors to guide us, Professor Shubhankar Choudhury, Professor Nilanjan Sengupta, Dr. Moutushi Rai Choudhury, Dr. Ashish Bosu, Dr. Pradeep Rai Choudhury, Dr. Kaushik Pandit, Dr. Vivek Rai Choudhury, Dr. Dasarathi Sarkar. There are many names. I'll miss out on names. I apologize in advance if I miss out on names. And there are a host of colleagues and juniors who have helped us out to plan this entire thing as well. As you might have noticed, this is a new venue, a state-of-the-art venue, but this is the first time a medical conference of this size is being hosted here. So a lot of arrangements had to be made, the proverbial alpine to elephant, as you see the electronic Pradeep. So there are a lot of innovations that had to be done to ensure that a scientific conference could be done in this state-of-art venue. And I think I would also like to thank a host of other people. Of course, the managers and the administrative staff of Dhanodhanno Auditorium, who have gone out of their way in a variety of ways to help us. our decorators, Bulbulda, our printer, Topuda, our office staff, we have Pradeep, Chandon, we have Robinda, and a host of other people who have helped us in our endeavors. Of course, I would also like to specially thank the pharmaceutical companies who have stood behind us. As you know, costs have gone up, so they have helped us fund a good portion of what needs to be spent for this conference, and my thanks goes to them beyond this sponsorship part, because spreading news about the conference, registrations, helping with the logistics, they have done a huge part, they have a huge part to play in the success. If this conference turns out to be a success, they have a huge part to play there. I think there are several other people, the audiovisual team, Mr. Somnath Sardar, and a host of other people whom I would like to thank. I apologize in advance if I have missed out on any names, because there are a lot of people involved behind this, organizing this conference. And as the proverbial saying goes, if you find that things are good, do give us a pat on the back, but more importantly, if you find that something can be improved, do let us know so that we can try to make that improvement the next time we do CRESCENDO 2024. I won't take any more time. We have a delicious dinner ready. There also we have an innovation. We have a separate caterer. I would like to thank them as well. 6 Baliganj Place, who has prepared a delicious dinner for you. I would request all the non-members of the Endocrine Society of Bengal to kindly proceed for dinner. Dinner is ready. And I would request the members of Endocrine Society of Bengal to kindly stay back for the annual general meeting. Thank you.